What's up, everybody? Hope y'all are doing well. Congrats on the white coat yesterday. That's awesome. Now you get to earn it. So Lindsey's here. You want to tell them what's up, Lindsey?
Yeah, so I'm here. I have a completion exam in 2 days, so I will be studying through this to make sure I do well. So I will be here, but I'm not here. So, but I wish you guys luck, and please wish me luck.
So yeah, wish Lindsey luck. Kishore, my buddy Kishore's here. He's starting term 3 tomorrow. Yeah, tomorrow.
Yep.
But he is here for he's going to help me out. The weather's been bad here, so if it goes out, Kishore will pick up. We'll go from there. So here's the agenda. Y'all have officially made it to the big leagues. We're like actually doing clinical medicine now. So you'll see a change in the way we do this. A lot less questions. Y'all could do questions on your own. This is going to be a lot more conceptual, a lot more of me talking. So y'all love that. So I know y'all just touched on EKGs. I'm not sure if y'all were able to really look at it yet. Don't stress, we're gonna go slow. We're gonna walk you through it. I have my own way of doing things. There's so many methods of reading EKGs and calculating heart rate. My advice would be to pick the one you like and stick with it. Preferably do the same one as me because it works. So if it works for you, go with it. Other than that, go ahead.
So I'm going to interject here, and Kishore is the term below us, so I'm pretty sure he can attest to this as well. Learn what we are going to tell you about EKGs, but if you are down to the wire, you only have a few hours to study before the exam and you want to pick something to study, do not pick EKGs. Yep. Because there are a lot of slides on EKGs, but there are not a lot of questions on EKGs. And so still look over it, still familiarize yourself with it. But the way it's presented in lecture is a lot more stressful than actually how they're going to test it. So again, if you're down to the wire, EKGs are not what you need to spend your time on. Learn what we teach you today, get comfortable with it, and then call it a day.
And I just want to echo that too, because when we got tested, we spent hours upon hours learning EKGs. And you know, you guys can get an entire fellowship on just electrical conduction of the heart, like, and EKG readings. Like, so they don't expect you guys to be cardiologists overnight. So make sure you guys focus on the clinicals, like Brady said. And if you're down to the wire, like Lindsey said, make sure you guys know the disorders, pathologies, and then just call it a day with that. Like, you don't need to know the ins and outs of EKG, every single lead and every single placement for this exam.
Correct. And so we're gonna walk through it, and I'm gonna tell you what's important and what's not important. I'll explain to you why I do my method. It's a fail-safe method, but I'll explain it to you when we get to it. That being said, I guess we'll go ahead and get started. I am assuming that they haven't changed the curriculum too much since in the past terms. If for some reason we get to a topic that y'all haven't covered yet, just let us know and we'll adjust accordingly. All right, so we have to do our, just in case we have anybody new here. Remember, term 1 channel, if you go to the Scrubs page, you can't search the videos, they're technically unlisted. So if you have to bookmark this link here, it will bring you to this. And here, if you bookmark this, you have all of the term 1 lectures or reviews that we've done so far since Lindsey and I started this thing. So everything will be posted here. The easiest way to do it is just bookmark it. Everything's there for you to look at. So I'll have it posted hopefully by the end of today. Also, this is not affiliated with school or IEA, but if y'all don't follow IEA, y'all should. Once we start in August, we're gonna do facts of the day for you guys, some important stuff. And for those that are fortunate enough to get above a 90 this term, you'll be able to join IEA. There's a bunch of fun stuff with that. Okay, now, So here's I want to do this. Y'all probably don't need to take notes on this part. Well, let's go through this. I run scrubs, Lindsey's on Diaphragm, and make sure you go look. I put up the stuff on the additional resources for you guys. A bunch of good extra stuff, including extra questions. Try to do the old IEA questions closer to the exam. But a good bunch of cool stuff. I pull stuff from first aid, and I don't know, anything on there, just thumb through it, and if something looks appealing to you, then download it. All right.
On my drive, real quick, I have a CPR review. It is an exhaustive review. It's the only exhaustive review on Google Docs that I made, but I've had people tell me that they print it off and annotate it, and it works really well. So if that's something you want, go to Dog Mom, Google Drive, Term 1 CPR, and it is in there. It also has lymph in there, which Brady was saying they change it up a little bit after us. And so I don't think they actually teach you guys lymph and CPR once, so you can just disregard that.
Okay, so you probably don't need to take notes on this part, maybe just listen. So late at night when I'm trying to sleep and I'm staring at the ceiling, I try to wrap my head around a good way to kind of explain this or kind of understand it in like a holistic view, right? So I'm just going to walk you through how I understand the cardiovascular system, and maybe that will help you going forward. So the way the way I think about it is that the heart is two separate pumps, all right, and they work in unison. If the cardiovascular system was a simple pipe system, then everything you pumped out of one side would just return to the other side. But it's not like that. It's a very dynamic process. So I talk about the right heart versus the left heart. Two separate systems working separately, but they work in unison, right? So whatever happens on one, the other can compensate. Now, I like to think of it like this, because when you start breaking down the different pathologies, when you break down the Guyton cross plots, when you even look at the math, whatever happens on the left side doesn't necessarily correlate to the right side. They're independent of each other's. So think of them as a marriage, right? They're two separate entities, but they work together to get the same job done. So the left heart, let's talk about it. It's the powerhouse, right? It's very thick in musculature, and its job is the pumping action, right? It pumps to get blood to the systemic circulation, right? Its whole goal is to take the amount of blood necessary and get it to the organs so they could be oxygenated, okay? So it's very strong. If you look at a cross section of the gross anatomy of it, you'll see that the myocardium is much thicker, okay? Now, when you get to the right heart, it's more delicate, okay? It doesn't pump at the same pressures. Now, the immediate question you ask is, well, if it's delicate and it's not pumping with the same pressures, how can it compensate for the same amount of blood going from the left heart to the right heart? And this is the analogy I like to use. Think of the blood as a big river, right? And if you think of a big river, as you break it down into smaller rivers and smaller tributaries and streams, the pressure goes down, right? You still have the same amount of water in those small streams as you did in the big river. It's just a lower pressure system, right? As it branches apart. And that's what happens in the lungs. You take all this volume and you branch it throughout the lungs, right? And so that pressure dissipates. So whereas the left heart is pumping at basically your blood pressure, right? 120/80, the right heart's only pumping at like 25, okay? And the way it's able to do that is by this branching pattern. So that helps me think of it. And it's important to be able to do that because you don't want a high pressure system in the lungs. You want it to be low pressure. You want it to get very finite, right? So single cells, red blood cells passing through these small little arteries so that the alveoli, the oxygen can be transferred, okay? So that's the idea there. That's how the right heart and left heart work together. And being that it's like that, one so strong, the left heart versus the right heart so delicate, the math is different, okay? But when I think the left heart, I think of mostly this pumping action, right? This forward flow. And when I think of the right heart, I think of a lot of returning to the heart. And that's what happens when you look at the Guyton cross plots. So we'll elaborate on that a little later, but you can see that if the left heart has problems pumping, the right heart can compensate by bringing more blood to the heart, okay? And the same is works in reverse. If you have a low blood volume getting to the heart on the right side, the left heart could pump stronger. So they can work together to optimize the same goal. Now, one huge concept that I want to point out is the idea, and we'll get into it a little later, this is just an intro, is the idea of preload versus afterload, okay? So preload, and you can define this in many different ways, preload is the same thing as your end diastolic volume. It is the maximal amount of pressure in the ventricle before you start ejecting, okay? So that's an easy concept, right? The maximal point, right? So like if you blow up a balloon, the maximal amount of air in that balloon before you let all the air out, that's your preload. That's your end diastolic volume. Now, when you think of systole versus diastole, you could simply change the word around. So systole is ejection, okay? Diastole is filling. So if you say end diastolic volume, you can also say end filling volume. All right, so it's the maximal point of filling before you eject. Now, afterload is a little more complicated. So I'm going to just draw this out because it's so important clinically, because you will all see patients that have high blood pressure. You will all see patients that are in cardiac failure. So you'll have to understand this concept, but primarily this idea of hypertension or high blood pressure really works for afterload. So let's say this is the aorta, and this is more theoretical than anatomical, right? But let's say this is the left ventricle. All right. If I said in this aorta, you have hypertension, right? High blood pressure, then right through this area, that means it's very hard to pump blood from here into here, right? Because this pressure is high. That's high blood pressure. So what happens if you have high blood pressure? That means that left ventricle has to squeeze against a lot more resistance, right? So what happens? It's just like working out your muscles, just like working out, your biceps or whatever, right? This myocardium over here gets a lot thicker, okay? Now y'all deal with the pathology a lot when y'all get to term 4, but you can imagine if the walls of the heart get too thick, then you can't fill it very well, right? The actual ventricle gets smaller, the area inside to fill it gets smaller, and that produces problems, okay? So this concept of afterload is very important. This is why your patients have to be on blood pressure medications. You have to monitor it because it's technically a silent disease, right? You really don't, you may get headaches, but you really don't get symptoms of hypertension until they show up clinically. Okay, so when we get to the guiding cross plots, we'll talk about this compensation mechanism a little more, but I just want to elaborate a little more on the vasculature, right? So it's even more dynamic than just the right heart and left heart working together. You also have the vessels, right? So if you're working out, your vessels vasodilate to your muscles so that you can get oxygenation there. If you've just had a meal, the arteries and vessels will vasodilate to your gut so that you can digest. So it's always this dynamic process. Who needs blood more, right? Kidneys always are going to need blood. Your liver sometimes, gut sometimes, it depends, right? So it's always this dynamic process. But when you think about the math of it, once you pump out the left heart, get all the blood to the circulation, get it to the capillaries, you've really dissipated all of the pressure. Now, what's interesting, and one of the more difficult, I really didn't learn this to med school. I was like, this is very, you don't learn this in undergrad or whatever. But when you get to the venous system, right, we go through the capillaries, we got very mild flow, and then we get into the venous system. The venous system actually has pooling systems, right? So it's not like you can say, whatever you pump out of the left heart goes through, and then that amount is going to get back into the right heart. It basically just pumps through the left heart, through the capillaries, and gets to the pooling system in the veins, right? What does that mean? It basically means that the veins have valves, the larger veins have valves, and then there are pools of blood, right? So as the heart needs more blood, you can actually vasoconstrict the veins and those pools get smaller. So you can actually titrate or modulate the amount of blood going to the heart from the right side by modulating the size of the pools, right? If you need more blood to the heart, you shrink the pools and it goes back. So again, the math works out separately from the right heart and left heart, simply because they do independent processes, but they work together to keep the constant blood flow, okay? So we'll go over this again as we talk about it, but I think by separating them, a lot of the concepts, the more complex concepts, work out. So I hope that made sense for you guys. All right, and that's what we're looking at here. So some of the introductory stuff, the series, yeah, so this isn't super important, but just know that there's branching patterns. We talked about this once you get to the capillaries. Some of the classic blood flow is through a series, right? One to the next, in a series. So y'all remember that from physics, but sometimes they are also parallel arrangement. And you can see that here, and this is what I was talking about. You can vasodilate and vasoconstrict to modulate how much blood is getting to the different areas, depending on their oxygen requirements, okay? So these are super important, these equations, and these will come back again and again, these concepts of stroke volume, and it makes sense. I want the math to make sense for you guys. So infilling volume versus minus infilling volume minus indigestion volume, okay? That's basically how much volume you've put out, right? Your stroke volume, when you squeezed, when the ventricle contracted, how much volume got out. Whatever was there right before you contracted minus whatever was there after contraction, right? So that's the amount of blood. It's pretty cool, actually, if you look at it, the way the heart works. When it contracts, it kind of twists, and it's almost like wringing out a towel, right? It's an efficient way of actually ejecting blood out. So it twists a little bit, and you can think of it like that. But as for this equation, not 100% of the blood gets out every time you squeeze. So there still is a little bit left over, but the amount that is in there minus the amount that's left over is the amount you put out, okay? Then ejection fraction typically is about 55-ish%. Okay, so that if that number is lowered, there's a problem, right? If you're only putting out 20%, patient's probably in some sort of heart failure. And then this one's super important too, right? Whatever volume you put out times your heart rate is going to be your cardiac output over a minute, right? Typically. So that's going to tell you the total cardiac output. So make sure to know these. The math's going to be important for you to understand. All right, y'all could go ahead and try these. We have a few questions put in here. Just send in the chat, private message. Yeah, so this one's pretty straightforward. The concept of atherosclerosis. So any sort of LDL, y'all have done this in back in FTM. So LDL kind of promotes cholesterol coagulation. So the more LDL and the more cholesterol you have in your circulation, the more likely it's going to attach to the walls. Now, anytime you get some sort of nicks or injuries to the inside of the vessels, inside of the arteries, those are little places that can commonly get plaque buildup. That's typically cholesterol. And yeah, you could see that there. So we see this here, yeah. All right, so make sure you definitely don't confuse the two. Arterial sclerosis is basically just hardening. They kind of work in concert, they work together, but arterial sclerosis is just the hardening, happens over time. But yeah, so atherosclerosis is going to be this plaque buildup, right? And it's very interesting because you'll have patients will come in and they'll check the carotids, and you know, you really don't get symptomatic until there's significant stenosis of these vessels. Like, you know, patients come in, it's like 70%. It's like, you mean only 30% of the blood that's supposed to be going to your brain is going that way? Like, so it's significant, but it's very amazing that our bodies can compensate up to a certain point. So when you, by the time your patient, even same thing with the kidneys, a lot of things, the liver, by the time your patients come in symptomatic, right? They come in jaundice, or they come in with decrease urine output. It's usually they're down to like 20 or 30%. So it's very amazing that our bodies can compensate to up to such a significant point. All right, and this is what I was saying, this injury, you can see any sort of injury as a conduit to these plaque builds up, okay? So it happens over time. All right, try this one. You could send the answers to me or Kishore, it doesn't, it's fine. Yeah, right, so it's C, tight junction. How do you know what kind of muscle this is? Little trick, for skeletal muscle, the nuclei are pushed to the side. So you can tell that. If you were looking at a longitudinal cut, I might have a picture of it. You can always tell cardiac, so cardiac and skeletal are both striated, but cardiac muscle branches. So if you see branch points, that's cardiac muscle. Yeah, so different type of arteries here or capillaries. They have the continuous ones. They don't really have holes in it, no need for them, right? But you also have different ones that are fenestrated, right? So they have little holes like in the spleen, they're fenestrated. And they have these little holes there that allow the blood to seep out. So it depends what organ system you're in. What's the other one? There's continuous, something, and then fenestrated are the big holes. What's the middle ones? I'll think of it. Anybody? Then fenestrated, sinusoidal, that's it. Yeah, so you see those. Sinusoidal is in, you see those in like the liver and stuff. Yeah, so good job. All right, try this one. All right, cool. So we're looking at A here, right? So that's going to be your tunica media. You see this arrow here, that's going to be your tunica intima, right? Remember that big layer, and it does say we're in the aorta, right? So that big layer A is going to be the media, and then this is your adventitia, right? The outer layer. What's interesting about this is that you see how thick this layer is? It's got a lot of elastic arteries, and it has this recoil principle. So as blood comes through, it kind of bulges out, but with the elastic arteries, it pushes it down. So it causes unidirectional flow. It helps with that flow due to this recoil effect, right? Bonus point if you have somebody with Marfan syndrome, right, and they work out too hard or they exercise, what layer is typically injured? It is also the media. Remember that fibrillin, that protein that is messed up in Marfan's, is part of elastic arteries. So this is why those Marfan's patients, they're at risk. Yeah, they're at risk for aortic rupture, and that's because they get this dissection in this tunica media. But you could see, you could appreciate how thick this is, right? And it needs to be because the aorta has so much, such a high pressure, right? Even better picture of it here. You see this tunica media, see all these elastic fibers, so you get this recoil effect and this flow down. Typically, you don't have to know numbers, but these are some numbers you probably want to remember. I feel like these came up. This 40 to 70 layers of elastic lamellae. Need to know that. Need to know them for each of them, just in case. But the less you have to, my goal in life is the less I have to, the more I can understand and the less I have to memorize, the better, right? Because that's the stuff that sticks with you. Even when you're stressed on an exam, if you understand it, you'll be better off. But unfortunately, some of these numbers, you just need to remember. All right, try this one. That's my dog snoring, if y'all are curious. She's not about that CPR life. All right. Good. Yeah. So this is that thick myocardium, and you could see the fibers running in different directions, right? These are kind of poking out at the screen, and these are longitudinal. But yeah, that's that thick myocardium. You see the ventricle over here. And you can even appreciate it more here. Epicardium on the outside, the thick myocardium. Here's your, this is the ventricle or the aorta, depending on where we're at. Maybe it's the aorta. I'm sorry, not the aorta, the atrium. And then the endocardium is this lining. Remember I said the difference between cardiac and skeletal? You see these branch points? That's your giveaway. Plus the nuclei are a little bit larger, but you see these branch points? Those are going to be indicative of cardiac muscle, okay? Cool. Here's another one. Yeah, so same thing we talked about. This is a big old plaque, right? And when you get to term 4, they're going to dissect, not dissect. You're going to investigate the different types of plaques and which ones are more prone to rupture than others. But this looks like a little stable plaque. You could see kind of little lipid droplets over here, but because this layer's thick right here, this is less likely to rupture, okay? But some of them are not as thick as this. So you get a rupture, you get myocardial infarctions, you can get a stroke, something like this. So this is classic atherosclerosis. But look at this, appreciate what this is. This is the vessel. Blood is supposed to fill this entire thing, but it's only going through here, right? You go try to work out it, you only get that much blood flow, right? Start getting chest pains, angina, and that's how it all gets started, right? So yeah, same picture. Not reperfusion injury, but just trying to compensate with these injuries here, just a response to injury, and you get these lipids that develop. All right, try this one. We're going to start talking about the mediastinum now. It is important to know what parts are located in what region versus front, anterior, posterior, superior, middle, and inferior. All right, hoarseness. Why are you hoarse? Bloody sputum, coughing, not bad of a temperature. You're good there. Growth on the aortic arch, interesting. So this is kind of a cool concept because like, you think hoarseness, you're like, I don't know, something's wrong with your throat. I don't know. But as it so happens, this left recurrent laryngeal nerve wraps around the aorta, right? On the left side. Remember the aorta, the arch of the aorta goes to the left. So during embryology, during development, this left recurrent laryngeal wraps around the aorta. So if you have some sort of growth of the aortic arch, it's going to press or impinge on this left recurrent laryngeal. And so your patient will present with hoarseness. Very cool to be able to diagnose something that has to do with the heart based on the change in their voice, right? So yeah. Let's see. There's another concept. I'm not sure if I have a question on it, but also dysphagia. What does dysphagia mean? Right, difficulty swallowing. A lot of times if the right atrium, actually I do have a question on it. If the right atrium is enlarged, it's the most posterior part and it presses on the esophagus, right? So you have problems swallowing. But these are the kind of things they like to test on. This is multi-components, right? So yeah, good concept to know. You could see it here on the left side. This left recurrent laryngeal wraps around the arch of the aorta. So if you have some sort of dilation, sometimes they commonly talk about syphilis, tertiary syphilis can cause this dilation here. It can impinge on this, and this recurrent nerve will cause hoarseness. The larynx right here, y'all will get into all that in term 2. And on the right side, since there's no arch, it wraps around the right subclavian. Don't see too much pathology there, but they love asking you about the hoarseness. All right, try this one. And if y'all don't highlight on the exam, I would you know, I would start highlighting with your practice questions, but I do it on every question, every exam, because I find it helps to, when I go back through the questions or even going through it, it slows me down and makes me focus on the important words. So I'm sure I've told you all this before, but being methodical through these questions, especially when you're taking exams, will help with the stress. You want to do the same thing every time, right? Go through, mark the ones, mark, even if you don't know it, mark the best answer, but flag it so you can come back. It should be very methodical. But I go through the process, even when I do practice questions, I highlight just the little things, right? Okay, difficulty breathing, right? Pain over the left shoulder, right? Left shoulder, interesting. They don't just tell you this just for fun, right? This is important. All right, so clear breath sounds bilaterally. Okay, so probably not something to do with the lungs, okay? Then we have the problem, aneurysm of the aortic arch. So what are we talking about here? Why are we having difficulty breathing? Why is there pain over the left shoulder? Well, if you remember, the phrenic nerve, C3, 4, and 5 keep the diaphragm alive. That makes up the phrenic nerve, okay? It also passes down around the aortic arch, okay? And if there's some sort of compression there, it can affect the phrenic nerve. And since the phrenic nerve innervates the diaphragm, which is a major component of breathing, you can get difficulty breathing. So when you look at this question, you should be asking yourself, well, aneurysm of the aortic arch. I know that the branch of the vagus, the left recurrent laryngeal is a problem there, but it doesn't say anything about hoarseness. Okay, what else travels there? Well, the phrenic nerve does, right? And if that's the case, you can get dyspnea, okay? And you can see that here. You see this phrenic nerve travels down as well, goes all the way to the diaphragm. All right, try this one. All right, a few more seconds. Yeah, Kishore gave it away. That's the good one. If y'all don't know, this mnemonic, I ate 10 eggs at 12. These are the locations where everything exits the diaphragm. The inferior vena cava leaves at the vertebral level 8. The esophagus leaves at 10, and the aorta leaves at the level of 12. So we want to know what's going on. Why are you getting this abnormal gas-filled structure? Well, we're either asking, if you look at the questions, remember, use the test to your advantage, right? If you're kind of confused, go to the answer choices and kind of see what we're talking about. Does the aorta have anything to do with downstream gas-filled structure? No, right? It has to be the esophagus, right? It's swallowing air or something abnormally. So this gas-filled structure has to do with air being filled in the stomach, right? This retrocardiac, it's going through the esophagus. and abnormally, right? So you could see that on chest x-ray. So then you just have to know, right? So we chose, so no aorta, no aorta. So it's got to be esophagus. So then we just need to know at what level the esophagus leaves, 10 eggs, esophagus at level 10. All right, so yeah, but that's good to know, that mnemonic. That's why I put this one here. I want y'all to know that. All right, and you can see it here. 8 I8 inferior vena cava, 10 eggs, esophagus, aorta's at 12, right? So for whatever reason, there's probably, I didn't actually read the question. There's probably some sort of herniate and some sort of backflow through here. So there was some sort of rectocardiac gas being filled, so that you know, it's obviously the air is coming through the esophagus, okay? Not the aorta. The aorta is filled with blood. You wouldn't get any air from the aorta. All right, so let's look at some of the gross anatomy. Try this one. Chest pain, difficulty breathing, high heart rate, cough, fever. So could it be some sort of infection? Well, there is pericardial effusion. What does this mean? There's fluid in the sac of the heart. All right, what is this? That's when you drain the fluid out of the heart, right? Needle is inserted from the infrasternal angle, right? Up in here, pointed up towards the heart. Passes deeply, piercing the visceral pericardium. Which one's that? Visceral means organ, so it's the one, it's the layer closest to the heart. Entering the heart, all right? So you went too far, it's not good. All right, don't do that as a resident. So what are we talking about? So basically they're just asking you what layer of the heart is the most anterior, right? A lot of words just to ask you that. Right ventricle, right? Right atrium, left atrium is the most posterior and right ventricle is the most anterior. Is it right? No, it's, yeah, left atrium. Oh, we'll get there.
Yeah, left atrium.
Left atrium.
You're right. Yeah, left atrium is the most posterior. Right ventricle is the most anterior.
Okay, just making sure. Yeah, so you can see this darker brown area. That's your pericardium. If you get fluid in there, that's a problem. Why is it a problem? Well, the fluid doesn't compress, right? So if you get fluid in there, the heart can't expand as well. Now, if you can't expand the heart, you can't fill it properly. So your ejection fraction goes down. The amount of blood actually pumping through the system will decrease, all right? They classically call this cardiac tamponade if it gets bad enough. You can see here, we're lighting up fluid. So this is a T2 MRI. But you see this fluid that's building up around the heart. Again, when the heart wants to expand, you definitely don't want too much fluid on the outside of it because it won't be able to expand properly. You can see this fuzzy area around here. That's fluid that's built up around the heart, in the sac around the heart. So basically what they did, they took a needle, they went in, they wanted to get this fluid out, see if it's some sort of infection or what's going on. They went too hard, went into the right ventricle, okay? Widening of the cardiac silhouette. Why is it widening? Well, because you got fluid around it, right? So the silhouette, the imaging around it is. You could kind of appreciate the little difference in color between the dense heart versus the fluid. But yeah, that's what you're looking at. Try this one. Penetrating wound, chest, ice pick. It's not good. Cardiac tamponade. This is a good one to know. What is the triad called for cardiac tamponade? Beck's triad. What is it composed of?
You better not ask me, Brady.
Come on. All right. Hypotension, good. Why hypotension? Because there's a bunch of fluid around, so the heart can't expand properly. So the amount of ejection, the amount of fluid you're ejecting is less. Blood pressure goes down. Yes, distended jugular, jugular venous distension. Why is that? because the jugular veins feed into the right heart. So if the heart is not expanding properly, you're going to get a backlog of blood. And then, of course, for this question, distant or muffled heart sounds. Why is that? Because you got fluid around the area you're trying to listen to. So it sounds distant. Good. Make sure you know those. Beck's triad. Very good. Yeah, look at all that blood around there. Like the heart's not going to be able to expand properly. So a lot less blood getting to the body. Do a pericardiocentesis, right? Pericardium, get fluid out of it, right? Save the dude's life.
Hey, Brady.
Yes.
I want to jump in real quick. There's a couple of questions. I want to make sure everyone catches it. So when they ask about the left ventricle or the right atrium, I want to say whenever they're talking about the structures in terms of like in the mediastinum and they're asking a question about that, really just stick to what Brady had mentioned. It's the left atrium if there's any sort of esophageal problem, and if it's any sort of damage to the anterior aspect of the chest or anything, trauma, anything, it's likely going to be the right ventricle. If you guys know those two, you should be good. And also for any of that needling question, it's going to be not the left ventricle, it's going to be the likely the one that you're going to hit first. If you really mess up, it's going to be the right ventricle if you're going subxiphoid and you're trying to puncture through. So just those two questions I want to address so that everyone knows clearly. And I'm not just putting it in the chat because I'm personally messaging everyone.
I have a picture coming up of that. So yeah, thank you, Kishore. But I'll show y'all, we'll make sure y'all have it straight in a second. I have an axial scan of it so you can see. Okay, right, but if they ask about any sort of questions, remember they like to keep it clinically relevant. So they'll ask about the most anterior, most posterior. All right, head-on collision, trauma to the sternum. What heart would be most injured? Sternum, right, anterior side. So again, right ventricle is the most anterior part of the heart. Okay, so we're looking at it here. Oh, let's do this one. That's the question. Yeah. All right, so I outlined it here. Right ventricle is up here. Because of the scan, you're kind of getting the great arteries, but if you were to go a little bit lower, you could see the left atrium. Why is this dark like this? Well, because he has a carcinoma of the esophagus. That's why it's dark like that. So if you were looking for it, look for something weird. What stands out to you? Why is this so dark? It should be the same tissue density, right? But it's a cancer. So it showed up darker. Now, the point is that the cancer is pressing down in here on the left atrium. So it could be affected by this. Now, it also works in reverse. If you have some sort of dilation or left atrial enlargement, you can also press on the esophagus. So when you swallow, you get dysphagia, difficulty swallowing. Here's a good cartoon graph. You see this right ventricle. So when you do a pericardiocentesis, that needle goes in. If you go too far, right ventricle. And here's that left atrium. Look how close it is to the esophagus. So if there's any sort of dilation there, it would be secondary to, well, classically, it would be secondary to left ventricular hypertrophy, and then it would backlog into the left atrium. It would press on the esophagus and your patient would get dysphagia, right? You can see that here. All right. Chambers. All right, let's look at this. Try this one. Oh, yeah, sure. Yeah, the aorta. Yeah, see this big one right here? That's the aorta, right? So, right, so it comes, right, it would come up here and wrap around, like coming out of the screen, wrapping around to the aorta. You could see it larger there. You could see it here too, right? The big one, right? So remember, it's going to come up like, well, technically, okay, technically, you're looking at the patient, the feet are coming outward, right? So it would go from this angle, it would go up, it would go into the screen and out, right? You always look at these looking at the patient. So it would go into the screen and come out, but this is the descending aorta right here, right next to this carcinoma in the esophagus. Yeah. Can you see the trachea? The trachea is usually a clear, it would have branched out at this point. No, so you can't, but it's just a hollow area because it's air filled, but no, it's already branched at this point. All right, so try this one. And I know sometimes it's a pain, and like some of these words don't, you know, they'll throw a lot of medical jargon in there, and some of it doesn't seem relevant, but get in the habit of looking these words up and just annotating them, because as you go, I promise you, by the time you get to term 4, it's going to be to your benefit, because these words keep coming up again. Like that's a common one, difficulty breathing, but you're going to come across some that, and before you know it, you'll kind of end up knowing these Latin derivatives, right? Difficulty, apnea, or P-N-E-A is breathing, right? So apnea is no breathing. A typically means no. So you get used to things like that, and sometimes it'll save you in certain situations. All right, so we are looking at the chordae tendineae, the tendinous cords, right? So what actually happens, right? So blood's going to come from the atrium and go into the ventricle, and the valves is going to open downwards so that blood could get in. Now, when the ventricle begins to contract, you want all the blood to go into the systemic circulation. You don't want it to backflow. So when these valves pop back, they don't regurgitate, they don't prolapse back into the atrium. And the reason they don't is because they have cords on the bottom, right? These chordae tendineae, and these chordae tendineae keep it taut like this. Keep it in this position so that all the blood goes down through circulation. Right, I could kind of show you, right? So if we were looking at it here and we had the valves, these cords are going to hold the valves like this, right? So blood's going to go this way and these valves don't kick back up, right? So now there are some pathologies that'll cause this and you'll get regurgitation. We'll look at that in a little bit, but that's the idea of these cords. This keeps these taut so they're closed so that blood can go unidirectionally. All right, let's see. Now you kind of need to know the different areas because the chambers have different components to them. Fossa ovalis, we'll look at that. That's embryologic. That's where the foramen ovale was. So that's so you can bypass the lungs. But there are some different things. The crista terminalis here. Pectinate muscles are just the muscles around the heart. So yeah, that's the right atrium. Left atrium here, kind of similar there. And then you get to the ventricles, and here you can see those chordae tendineae holding the valves from prolapsing. The moderator band is the electrical component. It kind of holds this area so you can get proper conduction. And let's see what else. Trabeculae carnae, that's specific to the ventricles. And you can kind of see those on the walls there. Papillary muscles are the muscles that hold the chordae tendineae in place. Okay, so just some definition there. So now let's look at the valves. They have the atrioventricular valves, the valves separating the atrium from the ventricle, right? So these are your mitral, sometimes called bicuspid, but typically it's called mitral. Bicuspid means it has 2 cusps, right? Tricuspid, 3 cusps. And interesting, because the left heart is so much stronger and has so much stress on it, whenever you see pathology, generally when you see pathology, it's going to be on this side because of the force. The only real thing they talk about tricuspid on that side is IV drug users, because you're putting drugs directly into the venous system. It goes right back, it goes to the right heart. So you can get like bacterial endocarditis there. But typically you're going to see mitral problems, mitral valve prolapse, mitral regurgitation, but we'll get into that in a second. All right. So yeah, those are the cusps. You can see these here, these larger ones here. Now you also have the semilunar valves. Those are going to be your aortic and pulmonic valves. Those are don't have as much stress on them So they just have these half moons or semi-lunar. So again, this is more just nomenclature, right? They open up and allow blood to go through. Now, this is super important clinically, right? You'll wake up in the middle of the night and you should know this immediately, right? So right second intercostal space is going to be your aortic valve. Then you jump to the left second intercostal space, that's your pulmonic valve. Fourth, the left sternal border, fourth intercostal space, fifth, is going to be tricuspid, and your mid clavicular line 5-6 is going to be your mitral valve. Now, this isn't exactly where the valves are. These are downstream from the valves. This is where you listen because it sounds the loudest. So if there's any sort of pathology there, you can appreciate it. So it's much more important to know where you auscultate, but technically you should know the valve location too. Just remember they're always a little bit medial to the point where you're listening, right? They're a little closer in the heart. But definitely know these. Anytime, it'll be a giveaway on a lot of the questions, right? They'll say, a patient, there's some sort of murmur in the right second intercostal space. And then they'll ask you, what's the problem? Well, you can immediately identify that as the aortic valve, right? Then you just have to determine if it's a stenosis or regurgitation. So immediately, if they tell you the location, you can figure out what valve it is. And we'll go through the murmurs in a second too. All right, try this one. Here, yeah, this is exactly right. So. So, murmur heard the loudest second intercostal space on the right. What valve is that? The aortic valve. What chamber or vessel receives blood that is being injected through this valve? So aortic valve goes from the left ventricle to the aorta. Yeah, that's what's the problem. Okay, they could be more specific and tell, oh, they did tell you it's a systolic murmur. So does anybody know the murmur? Aortic valve during systole. We'll get into this later, but I'll just tell you, during systole, the aortic valve should be open. So if you hear a murmur at the, aortic stenosis, exactly. If you hear a murmur when the valve is supposed to be open, it's a stenosis. It's a stenotic valve. It's a narrowed valve, okay? If you hear a murmur when it's supposed to be closed during diastole for this valve, it would be a regurgitation because it's supposed to be closed, meaning it's regurgitating back through. All right, but we'll get into that in a little bit. Yep. Right, good job. And this is just from first aid. There's a bunch of nasty mnemonics. I'm not going to go through them. A physician takes money, other things too, but whatever helps you remember, just make sure you know those. All right, blood supply. There's just a couple of things they really like to test on. So this left anterior descending, also known as the left interventricular or the anterior interventricular artery. Very important. This is often called the widowmaker. And that is because if you get some sort of myocardial infarction there, it supplies blood to the anterior interventricular septum and a lot of the ventricle on the front, on the anterior side. So if you get some sort of infarction there or some sort of blockage there, oftentimes it leads to death just because it's such an important artery. So they would talk about that one a lot. They also have the posterior descending artery, posterior interventricular, or the posterior descending. These are used interchangeably. You need to know both names of it. And then there's smaller arteries that branch off, right? So if this is where the superior vena cava comes in, you have these SA nodal arteries there. The circumflex artery branches off and goes around. So you have the left anterior descending here or left interventricular. And you have this circumflex that goes around. And that's for most people, but we'll get into that the differences in a second. Now, what's really important are the veins too that go with it. Okay, but you could just see this is just another picture of it. You can see this this sinus here that drains back. So remember, yeah, anterior interventricular or the left anterior descending, posterior interventricular or posterior descending artery. Those are going to be important to remember. A circumflex wraps around and goes to the back. And this kind of shows the blood supply there that you look at. So you see here, this widowmaker supplies a lot of this interventricular septum between the right ventricle and left ventricle. So that's a big one there. Circumflex there. And then you can see this posterior descending or posterior interventricular there. And they love asking you these: what veins travel with those larger arteries? This is probably what you'll come across. So, oh, sorry, no, do this one first. We'll talk about dominance and then go into the veins.
They want to know what the dirty mnemonic is, Brady. I don't know what to tell them.
A physician touched me. There you go. Or all, yeah, I guess. There's dirtier stuff.
The other name for LAD, folks, is the widowmaker. They won't like address it like that in the question stems, though. It's going to be either given as LAD or, you know, they might spell it out too.
Okay, so a left dominant heart means that the circumflex wraps around and gives rise to the posterior interventricular. This is very simple. If it's left dominant, the posterior interventricular comes off of the left side. If it's right dominant, it comes off the right side. So yeah, most people are left dominant. I'm sorry, most people are right dominant, but some people are left dominant. Don't worry about codominance. That's not very important. But the idea, it just tells you where the distribution is. So a right dominant heart is classic, and that's where you get your posterior interventricular artery. But there's also left dominant, where the circumflex wraps around and the posterior interventricular comes off to the left side. So just dominance there. Okay, this is what I was talking about. They like to ask this: what veins run with what arteries? Yeah, so we're talking about the anterior interventricular artery, also known as left anterior descending, right? So the great cardiac vein is going to run with the anterior interventricular, or the LAD. The middle cardiac is going to run in the back with the posterior descending artery. So you see the anterior descending, this is great. So great in the front, middle in the back. Great in the front, everybody now. Great in the front, middle of the back. All right, good. So just remember that. And this is just a little summary. It probably won't ask you too much. Maybe it'll come up on you. I don't know. Did this come up on the term one thing, Kishore? The lab exam?
Yeah, it did. Sorry, in the lab exam, no, not specifically. They just asked for the main coronary arteries. Not like, they didn't get too crazy with like which one supplies which, or like the structures that it's given.
When in doubt, go with clinical stuff. That widowmaker is super important. The big ones, the veins that go with the big ones, the circumflex wraps around, the sinus drains everything on the venous side. Nerves, not terribly important. I mean, they're obviously important, but not in this concept, right? So you have this innervation. Remember, you're going to have Phoebe's knocked out. Sorry, guys. She's the boss, so she gets to sleep when she wants. So you get these visceral afferents. They're going to do the sensation from the heart. And then this cardiac plexus is going to help control. The sympathetics are going to be primarily in control of the heart rate, right? So it all originates in the in the heart region, the thoracic region, T1 through T4, this chain ganglia is going to control the heart rate. Parasympathetic innervation, remember that the parasympathetics is going to come from the vagus, down from the brainstem, and go to the cardiac plexus, and that'll help control the vasculature. I know she's knocked out. Hold on. Baby, stop. Too loud. I know. All right. She's good. All right. Try this one. Right, so classic scenario. Older guy comes in, acute onset chest pains, all of a sudden it's radiating down his left arm. As a physician, you better pucker up and do something about it, right? Angina pectoris, chest pains, angina's pain, right? And ischemia of the myocardium. Okay, so it looks like he had a recent MI. Sublingual nitroglycerin, usually first line treatment. Nitro is going to dilate the vessels to hope to relieve this chest pain, okay? So maybe he didn't necessarily have a full-blown MI, but it was constricted enough to get ischemia and cause chest pain. So he needs to be warned, low salt diet, watch your food, maybe get him up to the cath lab and get it checked out, all right? So what is the following there? So a bunch of words to ask you this last question. What is the referred pain? Intercostal brachial. So this concept of referred pain is very cool. Science is still out there. Some people say it's random. I think of it as kind of like this mechanism that developed over, evolution to actually tell us, right? Because visceral pain is very vague. So the idea that the visceral pain could kind of jump onto the somatic pain to allow us to know that there's something serious going on. Because otherwise, I mean, you may get this vague pain in your chest, but the fact that it can be serious and go down to your arm is kind of like a serious warning sign, like a way that the organs can tell your body that something's seriously going on. So right, so this is classic. This is this dermatonal distribution. So again, the visceral afferent pain fibers kind of tag along. They're very close to the somatic fibers. So remember, diaphragmatic pain usually goes up to the left shoulder, right? So don't get that confused with this. The heart will go down, radiate down to the left arm. Gallbladder pain typically is like T9 on the back, and there's different regions that have these. Appendix pain is usually midline around the umbilical region. So it's pretty interesting. Now you can see here this pain distribution. Intercostal brachial is technically T2, so that's where it tags along. You can see this blue area here. That's where you would feel this pain, right? Elephant sitting on their chest. That's what they feel like. That's what they classically say. With chest pain with the MIs. All right, so let's look at the cardiac cycle. We'll do this quick and then we'll take a little break. All right, so the lub-dub. What is the lub and what is the dub? So we're looking at S1 and S2. So take a look down here. S1 is systole. What did we say systole was? Systole is ejection. That they're synonymous for each other. So at this point, S1, the aortic and pulmonic valve are opening and you're pushing blood through the body. This also means at S1, the mitral and tricuspid valves have to be closed because we want unidirectional flow, okay? So blood's pumping through the body and then diastole is filling, right? So now the heart is filling up. Now it's very important your heart rate's not too high or you have some sort of arrhythmia, like your heart rate's not regulated on a normal pattern because you need this time for the heart to fill up, okay? So S1 is going to be systole, S2 is going to be the start of diastole. This is very important when we look at the pressure volume loops. All right, and you could see this here with the valve closures. So S1, lub, ejection, dub. Now, interesting, when I was younger, I thought that the sounds was actually the contraction of the heart. as it stands, the sounds are actually the valves closing. That's what you actually hear. So these is the AV valve closure, and then the semilunar valves open, pumping blood through the heart. Semilunar valves close, eight mitral and tricuspid valves open. That allows filling of the ventricles, okay? You can see that here. Now, it does get a little bit more complicated because we're gonna look at these graphs, because there is the point where the atria ejects, and then you get, and then the ventricle fills, and then you get this isovolumetric contraction. And we'll talk about this in a second when we look at the loops. I think it's a little easier to see it there. And then this contraction is gonna, same volume, you're just contracting the muscles until it gets to a certain point where the valves are forced open, and then you get this ejection, right? And same thing works on the other side. So stars on this side, you need to be able to do this. Just go through it and just keep going through it and telling yourself what happens. All right, so this is how I do this. Whether it's completely vertical or completely horizontal, you're only worried about one component at a time. If it's a horizontal line, all you're worried about is volume. The only parameter you're changing is volume. If it's a completely vertical line, the only component you're worried about is pressure, okay? So depending on what component you're worried about, you can determine what's going on. So let's start in the bottom left corner. This is where the mitral valve opens, right? So at the point when the mitral valve opens, picture it in your head. This is where we're gonna have diastole. The mitral valve's open, so blood's flowing from the atria to the ventricle, right? Diastole, filling. So what are we doing when we're filling? We're changing the volume. Are we changing the pressure? No, we're just changing the volume, right? This is all in the ventricle, all right, this graph. All right, so we open the mitral valve, we're increasing the volume, okay? Now we get to the point in diastolic volume or our infilling volume. Now that's the point when the ventricle is at its the most volume, right? The most blood. Now we're gonna close the mitral valve, and all we're gonna worry about now is pressure, okay? We're gonna increase the pressure in the ventricle, right? Isovolumetric, meaning there's no valve is open, okay? No valve is open at this point. The volume stays the same, but we're starting to increase the pressure. We increase the pressure, increase the pressure, increase the pressure until you get to a point where the pressure is increased, it snaps the aortic valve open, okay? So at this point, you're not changing the volume. You're just increasing the pressure till you get to a point where you're forcing the valve open. Now picture it, as the aortic valve opens, now all the blood is gonna leave the ventricle and go into circulation, right? So now all we're worried about is decreasing volume, right? We're looking at just the left ventricle. So we're decreasing volume here. We get to a point where it's in systolic volume, you see? That is the volume that's left over after contraction, at end contraction volume. So after it completely contracts, now the aortic valve is gonna close, okay? Now we wanna worry about this isovolumetric relaxation. So at this point, at this vertical point, again, just like this one, there's no change in volume. We're just decreasing pressure, decreasing pressure, decreasing pressure until we get back to the initial point where the mitral valve opens. Mitral valve opens. So during this time, the atria is filling up. Now the mitral valve opens and then we start filling again. So pressure increases, aortic valve opens, blood to the body. Aortic valve closes, left ventricle relaxes, mitral valve opens, we fill the left ventricle, we eject, well, I'm sorry, we have isovolumetric contraction, it's squeezing till it gets to a point, everything opens, blood to the body, relaxation, fill the ventricle, contraction, opens, goes through. Okay, so just kind of wrap your head around that super important component. I want to, no, let's do the, okay, yeah, sure. We could do this one. Yeah, so, but just make sure.
I had one question that came up. It was regarding atrial systole and equaling like ventricular diastole. That is technically correct. I mean, the definitional terms are correct. You guys are associating it right, but I wouldn't equate the two together. Remember, diastole is just when the heart, at one portion of the heart is always still, whereas the other systole is just when it's ejecting blood from one side to the other, whether it's eventually into systemic circulation, whether it's getting into the lungs. So don't put those two always together, because later on when you guys are covering disorders or any kind of changes at the ventricular level or at the atrial level, those parameters slightly change, right? You can have like ventricular failing, and that can, like, you'll see it in the EKG and all those things. So go more towards the fact, because you guys are learning the basic sciences of it, of just like the atrium just ejecting blood, the ventricle receiving that blood, and then eventually passing it to either systemic or pulmonic circulation.
Yeah, there's just a small component of atrial systole that it's a very short time frame to where atrial systole goes into ventricular diastole, right?
Yeah.
All right, so at this point, aortic valve closes. That's up here, right? Right, we've ejected all the blood, aortic valve closes, and mitral valve opens. This component 4 is this isovolumetric relaxation. So by definition, the only way you can have it can be isovolumetric, meaning that no valves are open, right? You can't change the volume if no valves are open. So just remember that these vertical components, no valves are open. So at that point, and then here, that's our starting point. Mitral valve opens, filling, isovolumetric contraction. Aortic valve opens, ejection, isovolumetric relaxation, okay? And I just want to reiterate it. So mitral valve opens, we fill. So this is our, at this point, this will be our end diastolic volume, right? And then at this point, we're going to start squeezing, right? Then the aortic valve opens, we're going to eject. This is our end systolic volume. This is the amount of volume left over after contraction, right? So then we're going to relax until the mitral valve opens. And we'll do so. I'll show y'all some of the math behind this because it's pretty straightforward when we get there. All right, now, this is where it gets a little more complicated. This is the last thing we'll do before we take a break. I know this is rough. So there are different pathologies that you look at and different components that you change. Once you get down the original graph, if you change certain things, the graph changes a little bit. You will be tested on this, so it's going to be super important. But yeah, we're going to go through all those in a second. But I'll show you. So increasing preload. What is preload? Preload is like saying if we're increasing our end diastolic volume, we're increasing the load of blood right before it contracts. So if you look at our end diastolic volume, this is our end filling volume. If we're putting more blood in there, we're increasing our preload, okay? So you could see that here. Now we're gonna break these down into the different graphs when we look at these murmurs and stuff. But if you increase afterload, you're increasing the pressure. Remember, pressure is on the y-axis. So if we're increasing pressure, you would expect this, okay? Increasing contractility, if you contract it harder, your end contraction volume will be less because you're pumping more blood out of the body. Okay, so you're gonna have, if you squeeze the heart harder, more blood will be ejected. So you have less blood after the ejection. Okay, so those are the different parameters there that you could work through. Now, don't make more of this than it is. All you need to do is break down the different components. So up here is our pressure, right? So this is our pressure loop. And look, this is where you can see this aortic valve opening, this isovolumetric contraction versus the ejection, right? So once it ejects, the pressure is going to go up and then go back down. Once the aortic valve closes, you get this isovolumetric relaxation, and so be it. So you can also see the aortic pressures here, and those are up here. You have this little bump over once it starts ejecting. And then you have the mitral valves down here. Obviously, that's a much lower pressure system than the aortic valves pumping through the aorta. You also can correlate this with volume. Remember, any sort of increase in pressure should decrease the volume as long as one of the valves is open. Okay, so by increasing pressure here, the aortic valve is open, you're decreasing the volume, right? You're getting rid of blood out of the heart. And then during diastole, filling, you're filling the volume, okay? So systole is ejection, you're getting rid of volume. Diastole is filling. This is the correlate, so this is our QRS wave, and we'll go through that later. This QRS is here because that is this ventricular depolarization. So you're going to get this squeeze. The bump I was referring to is just right here, this in the aortic pressure. This bump jumps up because you get a lot of volume coming through the aorta at this point, a lot of pressure. And then this phonocardiogram is just the sound you're going to get. So this is the ventricular valve closing. Okay, so you can see this QRS wave, and this is the sound you'll hear, this lub-dub sound. Okay, so you could just break these down independently, and but you can see it here how it goes. This is the one I want to skip. This is more convoluted than it needs to be, so don't worry about this question. And this is from first aid, so they kind of break it down for you. As for like these A, B, and C, they're not terribly important, but you can look at these this JVP pressures here if you want. But I don't know that they'll come up if they didn't really get into it in lecture too much. All right. Okay, cool. Thanks, Kishore. All right. So heart sounds, S1 and S2 are normal. S1 is our lub. That's our mitral and tricuspid valve closing. So you would expect that to be loudest on the left side because it's higher pressure in the mitral valve region. What region is that? Right, left side, midclavicular line, 5th to 6th intercostal space. Okay, S2 is going to be the lub dub. It's the dub component, right? It's going to be our aortic and pulmonic valves closing, which will be telling you you're about to start diastole or filling. So S1 is contraction, S2 is the beginning of filling. S3 and S4 are abnormal heart sounds. Again, this is more pathology based, so y'all will get into this a little bit later, but you see S3 at the beginning of diastole, and S4 is towards the end, right before systole. But y'all will get into that a lot more later. All right, so this is a pretty classic question of what they could ask you on your exam. So try this one. All right, so I'll show y'all how I do this. What do we know definitively? Okay, well, it's at the apex. What does that tell you? It tells you it has to be the mitral valve, okay? Then they tell you it's holosystolic, okay? That means it's the whole point of ejection. So during systole or during ejection, is the mitral valve supposed to be open or closed? closed, right? So if the mitral valve is supposed to be closed and you're hearing a murmur, then it's mitral regurgitation. Okay, so that's how you do that. So if it's supposed to be closed, insufficiency or regurgitation. Now, if they talk about a systolic murmur at the second intercostal space on the left side, like we talked about before during systole, that would be aortic stenosis, because during systole, the aortic valve is supposed to be open. So first rule, find out what valve we're talking about. Apex is mitral, then find out when it occurs during systole. Mitral valve is supposed to be closed. It needs to be closed because the aortic valve's open and you want unidirectional blood flow to the body, right? So mitral valve is supposed to be closed. Now, that would mean that if you heard something there, some sort of murmur, the blood is regurgitating back into the atrium. Okay, that's how you do those. The more practice you get, the better. All right. And this kind of explains what I was just talking about. It's probably good to know these. It may help you, like some ancillary data on the questions. But yeah, so this tells you when everything's supposed to happen. But depending on the valve, you could say during diastole, obviously it's filling the ventricle. So the mitral valve is supposed to be open. So yeah, so for mitral stenosis, it's during diastole. So they would say you hear midclavicular line during the over the apex, midclavicular line, fifth or sixth intercostal space. You hear this stenosis. I'm sorry, you hear this murmur during diastole, right? So that would be a stenosis, because during diastole, mitral valve is supposed to be open. And typically it's rheumatic fever, like secondary to it. After kids get rheumatic fever, if they mount an immune response to it, it's classically mitral stenosis. But again, that's term 4 stuff. A good hint for you though is this one. This is very classic. If you get a question about some 80-year-old dude, it's typically age-related calcification, and this aortic valve goes through so much pressure over a lifetime that it tends to get calcified. And then these are going to be good things to know too. You hear this crescendo, decrescendo. It's right. It goes up and down. That's what the best crescendo I got. So yeah, so you get that. So that's classic for this blowing murmur here. Where does our click? Did we see our mid-systolic click? Okay, we'll get to that in a little bit. All right. But yeah, so sometimes mitral regurgitation will have that. It's like, right, up, down, crescendo, decrescendo. But sometimes that mitral, is it stenosis? I think it's stenosis, has the, I'll come back with that after we take a break, I'm pretty sure. Yeah, it's mid to late. So mitral stenosis does have that mid-systolic click. So during filling, you have this stenotic valve and then it kind of clicks open. So you hear this during diastole, you hear this little click. I do have more slides on that coming up. All right, let's take a 5-minute break and then we'll get into some of the more complicated stuff.
While Brady's taking a break, I'm happy to answer any questions you guys might have. So whether through the chat or, you know, feel free to unmute yourself too. That works too.
Yes, regarding the mitral regurg one.
Yeah.
Because when I heard the apex, I thought left ventricle, but it wasn't the aorta. I thought aortic stenosis, but.
For which question? The last one we did with the 7-year-old woman?
The one before that.
The one before that.
Or maybe was it?
This one?
Yes.
So It's loudest at the apex. The apex is the apex is the region of the mitral valve. So immediately you know. So if they said it was the left second intercostal space, then you're talking about the mitral valve. I'm sorry, then you're talking about the aortic valve. Because they're talking about the apex, they're talking about right here, this area of the heart, your midclavicular line, fifth or sixth rib. So yeah, that's the apex. So immediately you know by seeing that they're talking about the mitral valve.
Yeah, and I think Yusuf put a great example in the chat. That mnemonic helped us a lot in terms of especially current T3s who are going into like, you know, clinical medicine and then eventually like micro and all of that jazz. It helped us a lot when we were going through this exam, because I used that mnemonic like multiple times to pick out the best answer, because I could just use the context clues between like, you know, hollow systolic murmur that told me like what type of murmur it is. And then they likely gave you a location. And from that, I could just like literally play a crossing out game of like, okay, is it aortic stenosis? Is it a mitral stenosis? Is there any like regurgitation? Like what is happening? So if you guys can do that exact same process that Brady, myself all go through, it's a fantastic way to even get the answer without knowing the full context behind each of these question stems. So also there was another question. What is MR?
I'm sorry, what was that mnemonic?
Mitral regurg. It's
it's in the chat.
Yeah, it's in the chat.
Yeah. So you could also do this backwards. Like let's say we're looking at systole or the ejection component of it. You could say what's supposed to happen during systole. Well, the mitral valve is supposed to be closed, so it's closed, and then the aortic valve is supposed to be open. So then that'll tell you during this ejection phase, if you hear something at the apex, the mitral valve, that's going to be mitral regurgitation. Regurgitation means the valve's supposed to be closed and it's not competent. So the valve is going to be, so blood's going to backflow, regurgitate or backflow, or the valve is insufficient, either way. And during systole or during ejection, obviously the aortic valve has to be open so you get blood to the body. So if you have some sort of murmur you hear, the second intercostal space on the left, that's aortic, so it would be aortic stenosis. And the stenosis means the valve's supposed to be open, it's just not opening all the way. Anytime you hear stenosis, that's a narrowed lumen or a narrowed valve, okay? It happens in the GI system. You have narrowed, bowels get narrowed, stuff like that. Vessels get narrowed. So stenosis is a common word. You could also do it for diastole. Diastole, yeah. So during diastole, filling, what's the mitral valve supposed to be? We're filling the ventricle, so it has to be open. The aortic valve is supposed to be closed because we're filling the ventricle. So if you hear a murmur, say in the apex region, that's our mitral valve. It's supposed to be open. So this is stenosis. The valve's supposed to be open. It's not opening all the way. So it's a stenotic valve. It's stenosed, calcified, or whatever. Aortic valve is supposed to be closed. So if you hear some sort of murmur there, that's aortic regurgitation. It's supposed to be closed. Blood's backflowing, regurgitating. And be careful because they could talk about the crescendo, decrescendo thing. Those are classic. Those are buzzwords for you.
There are buzzwords. If you guys hear like machine-like murmur, they love that for PDA. So
we'll get to that.
Yeah. So all of those can be helpful. There was a question in the chat about it. Just hang tight. We're going to go over the buzzwords for those. So, and if you guys need clarification, always shoot me a message or shoot Brady a message and we can kind of clarify.
I guess shoot me a message since Kishore starts class tomorrow and I'm on vacation now. Thank you very much. Term 4s we finished last week. So we just got our grades. So we're done. We get the month
Brady's
off.
just salty. He's just salty that we were balling it out and he was just like, I am dying in term 4.
Yes. I'm actually going to Grenada. I leave in 10 days. So I will be, our next review will be on maybe on the beach. I don't know. We'll see how the Wi-Fi is.
He'll bring the whiteboard to the beach, you know.
All right. Let's see. All right. Yeah. So yeah, for the people that'll be down there, so we'll do next term, come August, we're going to do the reviews live, but we're still going to stream them. So if you're online, you'll still have access to it. We'll figure that out then. But for right now, for this term, for you guys, I'll keep doing everything online. Yeah, no worries. Me and Lindsey will. So hopefully I see y'all down there next term. That'll be fun. All right. Are y'all ready to do this? Embryology, everybody's favorite. So the key here is, the key here for the embryology is that you want to focus on the problems. I have to close the chat, it distracted me. You want to focus on the problems, right? That's what they're going to ask you about. They're not going to give, you don't have to write an essay on how this whole thing works out and how it's built and the whole process. They want to ask you about the problems that develop. What are you going to see clinically? So we'll go through a few little things before that, just to kind of get your bearing straight. So when the aorta and the heart starts to form, it has like this tubular structure to it. So some of these buzzwords could come up. I want you to make sure you know these buzzwords. So it kind of forms like this, and then it ends up breaking down into the different areas of the heart. So you have this heart tube and this pericardial cavity that's going to form the visceral layer of the lateral plate mesoderm. So mesoderm tends to form these organs, the heart specifically, from the lateral plate. Just a few little things to make sure, buzzwords, just in case they ask. And then what is the embryological origin of the structures? Just in case they ask you, there was a problem forming the right horn of the sinus venosus. What is the deficiency as an adult? The wall of the right atrium, okay? So make sure you understand these and just kind of have a general understanding of, what turns into what. All right, so we'll get into the clinical components of this, which are much more interesting in my opinion. So dextrocardia or sinus inversus, they are different. So dextrocardia just means the heart's on the opposite side. So the apex points to the right. Sinus inversus means all the organs, including the heart, are flipped. Does anybody remember what disease we talked about that presents with sinus inversus?
Primary ciliary dyskinesia.
Yes, Cartagener's, right, or primary ciliary dyskinesia. So the problem is the cilia are messed up, and during embryological development, the cilia kind of help to dictate which side the organs go to. Now, as an adult, people with Cartagener's tend to have respiratory problems because the cilia can't move the mucus back up, so you can cough it up, so you get pneumonias. And men are often infertile because sperm need the flagella to move. So stuff like that. Okay, so you can see here, let's see. This is a tricky thing. I think it came up when I examined it. Don't think that, okay, there's a D loop and an L loop. So the D doesn't mean dextrocardia. It's just that it's just the way it turns. Like it turns the D way or it turns the L way. Like if y'all remember like stereoisomers from organic chemistry. But okay, we won't get into that. But dextrocardia is actually ends up being the L loop, but the D loop is the normal position. So don't assume that D means that, right? It just means the L loop is the way the heart turns to where you get dextrocardia. Okay, I just didn't want you to get the D's and the L's. See, because the D loop is actually the normal way. Okay, so those don't correlate. So if we look at the difference here, how can you tell the difference between dextrocardia and sinus inversus? Well, you can see here, the apex of the heart, the pointing aspect of the heart, right? There's about the mitral valve, is on the right side of the chest, right? You're looking at the patient. So this is the right side of the chest. Now, what's different here? You can appreciate, and this is what I use, if you see this gas bubble here, this gas bubble is the stomach. So you can see the stomach in this person is on the left side, which is the correct side. But over here, the stomach is on the right side, which is the wrong side, right? The esophagus, air goes down, tend to get a gas bubble. So that's a little cheat way of doing it. So you can see the heart and this. So this means all the organs are flipped. This just means the heart is flipped. Okay, cool. And then there's some atrial development type stuff. As for these septal defects, you kind of need to know them. But if you have a general definition for each of these, you should be good to go. So this patent foramen, this just means that the foraмен's open, right? It's patent. So between the septum primum and secundum. So like I said, if you have just this general understanding, this definition for it, you should be fine. Then they have these ostium secundum types. And you can see here, these are the different defects. But again, just know the definition for it. And then there's a few other ones. The primum type is buzzword, is failure of closure of the foramen primum, okay? So it's usually a problem with the atrioventricular valves. But again, you may get one question on this, but it would be straightforward. They would just ask you, they would give you this definition and ask you what kind of type it is, okay? So just keep that straight. And then, okay, you get this ventricular septal formation too. So you get this ventricle. If you don't have ventricular formation, you can get VSDs, ventroseptal defects. And there's two components that form in the ventricle, this membranous and this muscular component. Okay, and you can actually see that here, membranous component and the muscular. All right, and the main thing I want you to know here, these endocardial cushions, right? This component is going to be the interventricular septum, and that is common in Down syndrome. You can get endocardial cushion defects in other clinical scenarios, but this is common in Down syndrome. Also, you can get other defects in Down syndrome, such as VSDs, ASDs, PDAs. But when you talk about this endocardial cushion, a lot of time they're talking about Down syndrome. So this is the problem separating the ventricles and the atria, right? That big separation line that separates basically the right and left side of the heart. Okay, and then as always, when in doubt, if there's a question, it's usually, the answer is usually neurocrest cells. They like that. So I just wanted to include that. You can read this on your own, but it does play a component to development, right? These are the components, the partitioning, this membranous IV septum, and when the bulbous cordus splits. Okay, so this is from first aid. The ones you need to focus on are 3 through 6 right now. So whatever, if you want to use these little mnemonics, first aid is great for these. Third is the carotids or the common carotids. Fourth is where you're going to get this, the aortic arch, so where that left recurrent laryngeal comes around. And 6 is going to be the pulmonary arteries. Okay, so keep those in mind and where the defects can form from. All right, and this is kind of just in words what that was. Keep in mind when we talk about that left recurrent laryngeal, that's where you get these arches. Okay, this really tricks people up, but it is testable. So we're going to go through this. I think the best way to do this is in your mind, take a snapshot of what this is supposed to look like. Okay, we're looking at the patient. So this is the right side. So during embryological development, you see it almost looks like a heart, right? But these are the vessels, and during development, this part is supposed to involute, okay? And meaning it's supposed to disappear, right? It's supposed to go away. So if you have problems where this does not go away, it ends up you have problems with the great vessels. So take a snapshot in your head of what this is supposed to look like, and then we'll go through the deficits, right? So normally you're supposed to have involution of the distal right dorsal aorta. And we go back, that's this. Involution of the distal right dorsal aorta. That's what this is called. Now, let's assume this first scenario where it just doesn't involute, okay? It just stays, all right? So in this case, you get this double aortic arch, meaning this little part stayed, so when it developed, you got this little section and this section behind here. So clinically, what this can get problems with is dyspnea or dysphagia, difficulty breathing or difficulty swallowing, because you have this big muscular artery surrounding it, okay? So that could be a problem there. So if they say double aortic arch, they say persistence, right? It didn't involute. You have persistence of the distal right dorsal aorta. You get a double aortic arch. Okay, now remember our picture, this part is supposed to involute. Let's say the other side involutes instead. This can happen. And so this would lead to a right aortic arch. So basically, as an adult, when you develop, you get a right-sided aortic arch. Remember, the aortic arch is supposed to be over here. So if this side involutes, it kind of pushes everything to the right side. So by definition, this is involution of the left instead of the right dorsal aorta, and you kept the right side. Pushes it, so you get a right aortic arch. All right, remember our picture. This is what was supposed to involute. Let's say that stays, and this whole section involutes. So this is a little more complicated, but you get this this anomalous right subclavian artery. So basically, the right subclavian artery comes off from the left side. Okay, so these are just little problems that could form during development, and so this just means that the right subclavian artery has to come from the left side, okay, and wrap around. So here's our definition: involution of the proximal instead of the distal right dorsal aorta, and you kept that lower section. All right, so if you know those definitions, you should be good, but they could ask you this, any sort of problems, and ask you what the complication is. All right, and I put this again, right, don't forget.
Whoops. Uh-oh. Can you hear me?
Okay, I don't know why it does that sometimes. All right, and we talked about this, right? Here's our recurrent laryngeal. It wraps around during development, so it ends up when you're adult around this aortic, this arch of the aorta. So if you get some sort of dilation of this area, you get compression of the left recurrent laryngeal nerve, and you can get hoarseness. Okay, so let's talk about fetal circulation. Did I say wrap around the esophagus? It wraps around the arch of the aorta. Yeah. Right. So during development, when the fetus is in the mom, it is surrounded by amniotic fluid. So basically, the lungs are not developed. And the process of developing the lungs is that the baby has to swallow the amniotic fluid. So what this means is it's necessary for the circulation to completely bypass the fetal lungs. So the mom is able to oxygenate the blood, get it to the placenta, get it to the baby, and everything is shunted to the left side of the baby while the right side develops, right? It's baby swallowing amniotic fluid. So there's no oxygen exchange in the fetal lungs, okay, until the baby's born and that process goes through. So by shunting everything, by necessarily getting everything away from the right side, getting away from the from the lungs, we have to shunt everything to the left side. So it's necessary to have a couple of shunts. Now, you also have this ductus venosus. The mom actually detoxifies the blood too, so you bypass the liver. That's not important right now. What's important is that the foramen ovale, which is basically a hole, a foramen, between the right atrium and the left atrium. So you're going to go from a high pressure system to a low pressure system, right? That's going to, if there's a hole there, the blood's going to go from somewhere that's high pressure to the path of least resistance to the area of low pressure. Well, Because the lungs, all the vessels around the lungs are closed, that makes it a higher pressure system. So the blood is going to want to go from the right atrium to the left atrium, which is perfect because we want to bypass the lungs. Now, let's assume you also get some blood, right? Because it still can go to the left ventricle, but once it gets to the left ventricle, I'm sorry, it can still go to the right ventricle. So you have blood in the right atrium, you have the foramen ovale. So a lot of the blood is going to go directly from the right atrium to the right, the right atrium to the left atrium, okay? But some blood is still going to go from the right atrium to the right ventricle. Now, to avoid any blood that's in that right ventricle from getting to the lungs, you also have this ductus arteriosus. And that's going to connect the great vessels, the pulmonary vessels, from the pulmonary vessels to the arch of the aorta. Okay, so again, you're shunting blood from the right atrium to the left atrium through the foramen ovale, and you're also, if any blood gets to the right ventricle, when it's ejected there, it's able to bypass the pulmonary circuit to get to the lungs, and it goes directly into the aorta. So everything is getting into the left side. Okay, hope that made sense. This is from first aid if you want to just kind of have a little more understanding of it. So it's very important to understand this. Like I said, in a fetus, the right side is higher pressure system, right? The architecture around the lungs, the vessels, everything is constricted on purpose so that you can get everything shunted to the left side through the foramen ovale, through the ductus arteriosus. At the moment of birth, when the baby takes its first deep breath in, all of the vessels in the lungs, the alveoli, everything opens up. So you get this shift in pressure. So then at that point, the pressure on the left side, the stronger heart, is increased and the right side goes down. And that's the moment at which the baby takes its first breath, okay? And this is the point where classically the foramen ovale will shut because the pressure switch. So that's how that works. And then over the next few weeks, the ductus arteriosus will close. I think I have a slide that kind of tells you. So yeah, so the pressure change causes the foramen ovale. So it was a flap, right? It's a flap going from the right heart to the left heart. But once the pressure changes, it snaps back closed and then it stays closed because the pressure switched from going from right to left to going to left to right, right? Because of the low pressure in the lungs after the baby's born. And you can see that here. So the blood comes in and it's going to go to the left heart because as a fetus, right? This is high pressure, this is low pressure. But yeah, so when the baby's born, the baby takes its first deep breath in, right? It's out of the fluid, the amniotic fluid, and you know, the doctor spanks the baby on the butt or whatever, you know, and the baby takes its first deep breath in. And at that point, all of the vessels in the lung open up, so you get a pressure change. So at that point, the left heart has a higher pressure than the right heart. So this little part right here closes, and that's our foramen ovale. So at that point, instead of the blood being shunted from the right atrium to the left atrium, blood can go from the right heart to the lungs, okay? Yes, and then again, the ductus arteriosus, this has a lot to do with prostaglandins being formed. So you can see that, and I have a slide of that coming up, but also the oxygen levels help to close that too. So it takes a little bit more time. If it doesn't close, it does present as problems, but there are ways to artificially close that as well. So yeah, and this is just the words for it there, if you want to read those. So yeah, you could see here. So let's say, okay, so most of the blood is going to go from, as a fetus, high pressure system, right atrium to the left atrium, right through the foramen ovale. If any blood gets down into the right ventricle, it's going to go up through here. Remember I said that these vessels are going to be a lot high pressure, so path of least resistance is into the aorta. Okay, once the baby's born, the foramen ovale will close and then blood can go properly to the lungs. The lungs will have a lower pressure system. So that's the whole idea there. Now, prostaglandins will be able to keep the ductus arteriosus open. But you get a decrease in prostaglandins after birth. So it will actually help to close the close the ductus arteriosus. It takes a few weeks. If you need to do it artificially, you can give indomethacin, which is an NSAID, sort of like ibuprofen, stuff like that, which directly inhibits prostaglandin synthesis. So if you give that, it'll close the ductus arteriosus. Ideally, you won't have to do that. Just the normal decrease in prostaglandins, close it on its own. All right, so you can read this when you have time, but that's basically what I was talking about. Same thing here. Okay, so if we look at some defects that happen in this formation, these are the sort of things they're going to test you on. Let's say you have a coarcation of the aorta. This is very common in children with Turner syndrome. Little girls, remember Turner syndrome is XO, right? So you get one X chromosome and an empty spot. The O is the empty spot. These girls tend to be short in stature. They have the web neck, infertile, and they also can get this coarcation. So you can see this pinching here. So what this actually causes is an increased pressure going to the lower limbs. I'm sorry. This here causes an increased pressure right here. So the blood going to the lower limbs is decreased, right? Since the blood's going to want to go through the passive least resistance, it's going to want to go through these vessels up here. So classically, you're going to see increased blood pressures in the upper limbs and decreased blood pressures in the lower limbs. And that's due to this coarcation. Blood is not going to want to go down through the descending aorta because of this pinch point, right? It's going to want to go to the passive least resistance, which is the upper limbs. So these people that have coarcations tend to have decreased lower limb development. Also, this path of least resistance is this right here. So opposed to going down through the descending aorta, it'll go through the subclavian to the anterior intercostals, okay? And then it'll try to get to the distal aorta. Well, these are smaller arteries, and by going through those, you get this complication called rib notching. This basically is just this high pressure system. It's trying to avoid that coarcation, that pinch point there. So it's going through different pathways. So classically, yeah, rib notching is definitely a good word for this. So look here, blood's gonna come out to the ascending aorta. Look at this pinch point right here. So decreased blood is gonna go down to the lower limbs. The blood's gonna preferentially go through the intercostal arteries. Look how dilated these are. These are small arteries. They're not supposed to go through that much pressure. And by going through that much pressure, you get this rib notching. Okay, so now what you can do is actually give them exogenous prostaglandins. Now, what's that going to do? Remember, we said by having increased prostaglandin, you could keep the ductus arteriosus open. What that does is it actually allows you to bypass this point. Watch. So if you, let's say we had a coarcation right here, right? You identified it at birth. Give the baby prostaglandins to keep this open. That way, blood could actually flow. Though it is deoxygenated, at least you're getting some blood flow down to the lower limbs. So that'll help with the symptomatic development or the symptomatic problems there. So this is a method you can actually use, but it kind of just integrates the two different concepts. Yeah, so let's go through some of the shunts. So the left to right shunts are more straightforward. Why is that? Because the left side is a higher pressure system than the right side. So any sort of hole, just a hole you have, like a ASD, a VSD, a septal defect, the blood is going to want to go from higher pressure to lower pressure. So that's what we talk about in these left to right shunts. Okay, so yeah, so they tend to be acyanotic, no cyanosis. Why is that? Because the blood on the left side is already oxygenated. Okay, it's supposed to go through the systemic circulation. So if you get this oxygenated blood on the left side, the high pressure side, and get it to the right side, it's already oxygenated. Okay, so you don't get any cyanosis there. And we'll see the difference, the more important component of that, the cyanotic kids. So yeah, so when we talk about these simple holes, these simple septal defects there, atrial septal defects, ventral septal defects, remember after birth, that left side is, the left heart is the strong heart, right? So we're gonna be compressing and it's gonna be this high pressure system. So if you have a hole there, not only is it gonna go through the aorta, but it's gonna go back through the hole. But the blood that is getting through circulation, though it is less, it is oxygenated, right? So you want this unidirectional blood flow through the aorta. It is oxygenated, the kid will get oxygen, but you will get some backflow through this septal defect into the right ventricle. Okay, so acyanosis, no cyanosis. PDAs, now this is what Kishore was talking about. They talk about this as a whole, not holosystolic,
Machine-like.
Machine-like murmur, thank you. Yeah, so what actually happens if you look at systole and diastole, right? This murmur, typical murmurs only happen through one component. This murmur actually happens through the whole thing. So it's just, here's my machine-like murmur. Keisha, you ready? It's like, right? It's constant throughout, through systole and diastole. That you can go like on your phone and get like murmur. There's like free murmur apps and they do much better than me. So you could go listen to those and that'll help you out. But yeah, so this is the one murmur you need to worry about that happens throughout systole and diastole. Machine-like, it's all the way through. It's not restricted by any valvular structure. It's beyond the valves, okay? So, and classically they talk about a mom with rubella, okay? Maternal rubella during pregnancy, kid gets a PDA. What do you do for this? What do you give them? NSAIDs, right? Classically indomethacin, but yes, NSAIDs, very good. All right, now, this is a very important component too, because let's say we have this left to right shunt, right? Left to right shunt. So eventually, the left side is the high pressure side going to the right side through this shunt. Eventually, this right ventricle is going to get stronger, the musculature, from dealing with all this increased pressure. So there will be a point at which you have a switch. You're always worried about going from high pressure to low pressure. So there will be a switch over time to where the right heart actually gets fed up and it gets stronger than the left heart and it reverses. So at this point where the right heart gets stronger, it's going to shunt the blood back to the left side. Now, what does this cause? Much bigger problem here, because if you're shunting blood from the right side, which is deoxygenated, to the left side, then you're going to get deoxygenated blood through the systemic circulation. And that's a problem because you need to have oxygenated blood to the muscles, to the organs. So this reversal is a big deal. They call it late cyanosis or blue kids, not blue infants, not blue babies, but blue kids, because this happens over time. So again, at some point, the strong left side is going to be picking on the right side, and eventually the right side is going to get fed up. It's going to get stronger. It's going to fight back. It's going to kick the blood over to the left side. Then you get problem. This is when you start presenting with problems because you're going to get decreased oxygenation to the systemic circulation. All right, now the right to left shunts are tricky because you say, well, the left side is higher pressure than the right side. Why on earth would you ever get a right to left shunt? Well, there has to be a major structural problems here to get a right to left shunt. So we'll look at these. They are the terrible T's is what they call them. They all start with T's. There's also, they didn't put, which one did they skip? Tetralogy of Fallot, which is probably the most important one. So maybe add that into your notes as well, Tetralogy of Fallot. But we'll talk about it in a second. So again, these have to have major structural problems because you have to structurally cause a higher pressure problem on the right initially to have a proper right to left shunt. So and this is what happens here. Now, these are going to be blue babies. Why are they blue babies? Why are they cyanotic? Because you're shunting blood from the right side, which hasn't gone to the lungs yet. It's in the right heart. Remember, it goes right heart to lungs, gets oxygenated, then goes to the left heart, then the circulation. So if you get a right to left shunt, you're putting deoxygenated blood from the right side and putting it on the left side. That's a problem, right? So this is what we look at. Now, again, this is the first one we'll talk about, Tetralogy of Fallot. Tetralogy meaning 4. You have to know these. These 4 components during embryological development. This blue is important in case they ask you what is actually causing these 4 components. It is a problem with this septum, right? You get this anterior superior displacement of the septum. So this ends up causing this. Pulmonary stenosis, we could break this down. So if you have stenosis of the pulmonary output portion, right? You're increasing the pressure. The blood's not going to want to go through to the pulmonary vessels if it's stenotic, right? It's going to want to shunt somewhere else. Right ventricular hypertrophy. You'd expect that if you have pulmonary stenosis, right? Because the right heart really has to work hard. VSD, well, that's a problem too, right? Because if we have increased pressure on the right, increased strength on the right, and a nice little hole to shunt it through, you're going to shunt the blood from the right side to the left side. And then you also get this overriding aorta, which doesn't help with the pulmonary stenosis. So this is this perfect storm of problems that's going to cause this right to left shunt in these kids, okay? Now, what's interesting, well, we'll go through this first. Anytime you have a cyanotic kid, if they start crying vigorously, they're not breathing properly. So you could see what's called these TET spells. It just means when they're crying and they're not breathing properly, the cyanosis is exacerbated, right? It gets worse. What's cool, not cool, but it's interesting, you'll see these kids will start squatting, right? And what that actually does is it increases the venous return to the right heart. So what you're basically doing is to increase the pressure on the left side. So it's basically pushing back from the left side to help the blood stay on the right side. Okay, so you're increasing your total peripheral resistance. So it will help to make the right side help to make the left side a higher pressure system. So think of it like this, right? Sorry, let me get this out. You classically have a right to left shunt here. But the child's going to start squatting, right? So by squatting, you're increasing basically your afterload. You could think of it like that. You're increasing the resistance the left heart has to press against. So you're helping to reverse the shunt, or at least hold this back a little bit. So therefore, you can keep that deoxygenated blood back. It's kind of left heart saying like, stay on your side, get oxygenated, and then come to the left heart, okay? So obviously these babies aren't taught to do that. It's just been noticed that they do it, and it makes them feel symptomatically better, okay? 3 common things or presentations you could see with Tetralogy of Fallot. The George syndrome, remember that was our catch-22 syndrome. Down syndrome, you'll see it there, and fetal alcohol syndrome. You can see this. All right, so you could also have this persistent truncus arteriosus. Basically, this septum doesn't form between the aorta and the pulmonary valves, okay? So you get intermixing of the blood. It's not terrible, but because the blood isn't set as deoxygenated going to the lungs and oxygenated going to the body, it's mixed. You can get this mild cyanosis here. All right, and then you can get transposition of the great vessels. That's a huge problem because you're basically going to have 2 separate circuits, okay? You're going to have, so the right heart is going to go to the body, which it's not supposed to, right? And then the left heart is going to go to the lungs. So the right heart going to the body is going to be constantly deoxygenated, and the left heart is going to the lungs going to be constantly reoxygenated. So the only way these kids can survive is by having some sort of septal defect. And even then, it's still very severe cyanosis. So there's no intermixing of blood, right? because of these great vessels are switched. Then there's also this one isn't terribly important. It's a total anomalous pulmonary venous return. It just kind of means the venous circuit is mixed up and it could enter into any of these areas, but they usually don't test on this too much. All right, heart as a pump. Okay, so there are 3 components that you need to worry about. We talked about preload a little bit. We talked about afterload, which is the pressure you have to press against. There's also this component of contractility or inotropy. So by modulating your sympathetic input to the heart, modulating the amount of calcium you can get to the heart, you could increase contraction of the heart. It's very important, right? Because if you're in a stressful situation, if you're working out, you want to be able to contract the heart harder to get more blood out, okay? So this is this idea of increased contraction. Y'all kind of touched on it last in MSK with this preload, afterload, those muscle graphs. So it's just the idea that if you increase this inotropy, you can increase this force of contraction. I forget the guy's name. Stirling's law, right? Yeah, that's that. All right, you could read this, but this is, so we'll kind of go through these. This preload, remember preload is the same thing as in diastolic volume, that's your infilling volume. Afterload is your high blood pressure, your hypertension, the pressure you have to press against, and contractility is inotropy. All right, so preload first. Right, Frank-Starling's law, by the more you expand it, the more you're able to contract, the more the muscle fibers expand or pull apart, the more contraction you have, and that's up to a limit, right? If you expand them too hard, you can cause a problem. But the idea is the further you pull a rubber band apart, the more it's going to contract. All right, so, and you could see this. So we're expanding the heart up to a certain point. This is the point of no return. This is this point where the heart maximizes its expansion. From then on, it's a downhill slope. This is when you get into diastolic heart failure. You're expanding too far. But up until this point, the more you fill the ventricle, the more the muscles will expand, the more you're going to be able to contract. The more you fill, the more blood's there, the more you can contract, the more blood leaves the heart. So remember I said in diastolic volume or in filling volume is the same thing as preload. It's the amount of blood, the maximum amount of blood you have in the heart before you contract, okay? So if we increase the amount of blood in the ventricle before we contract, then theoretically, we're gonna increase the volume of blood ejected by the heart. Makes sense, right? In simple terms, the more blood that's there, the more blood available to get rid of, okay? So keep that in mind. So when we talk about afterload, remember we talked about this. This is a good picture. If you have some sort of stenosis, right? As you can see here, the pressure is higher, or the pressure is higher right here. So that's going to increase your afterload. So think of afterload can either be hypertension, right? Narrowing of this vessel, or it could be narrowing of the valve. Either way, you're pushing against the higher pressure here. If you're pushing in against a higher pressure, that's going to increase your afterload. If you have to do this over too long of a period of time, oh, sorry, that's terrible. You get muscle hypertrophy. If you get muscle hypertrophy, then the amount of blood that can get in here is less, right? So you can get into problems. Again, that's a term for problem, but just think about it like this. If you were blowing out of a narrow straw, you have to put increased pressure. If you have a bigger straw, it's lower pressure. So if you have to push this blood through a narrow straw, it's going to cause increased pressure. So it's increased work on the heart. So again, you get some pathological changes. You get hypertrophy of the ventricle. All right, in contractility, a lot of the components here are like the sympathetic innervation and then the calcium. Remember, calcium has to do with contraction. So if you look here, this is our control. If you increase the sympathetics that go to the heart, you're going to increase contraction. Let's say you put the patient on some sort of calcium channel blockers, which are very common, amlodipine, verapamil, stuff like that. If you block the calcium of the heart, you are going to decrease contractility. Okay, so decrease workload on the heart. That's how that works. Now, how does this affect end diastolic volume? It doesn't, right? So you still be able to fill the heart properly. This is just going to determine how much you contract, how much the heart is able to contract. It's not going to necessarily change end diastolic volume or the preload, right? This is the after effect. What about your end systolic volume? How's that going to change? Is it going to change? If you squeeze the heart harder, would this go up or down? The amount of blood that's in the heart after contraction. It's going to go down, right? If you squeeze the heart harder, the volume after you squeeze it is going to be less. You're squeezing harder, more blood's going to leave the heart. Yeah, I mean, it is more efficient. You could say that to a degree, but remember, you have to balance the idea of being efficient with working too hard, right? Because if you work too hard, you can get problems like the heart's working too much, right? So you get problems like hypertrophy and stuff like that. And again, if you get too thick of a muscle in the heart, then you can't fill it properly. So that's the thing. You could always say, well, why doesn't the heart just pump harder? You could always do more, but there's a balance there, right? You have to balance the idea of working properly versus working too hard, because you always want to stay in that middle range. It's working too little, you don't get blood flow. Working too much, you cause heart failure. And then when we talk about this in regards to contractility, again, the more sympathetic innervation, beta-1 receptors, if y'all remember, is going to help to remember is beta-1, one heart, two lungs. Beta-1 controls the heart. It uses that GS receptor, so increase CAMP, increase protein kinase A, will increase your calcium, increase calcium into the muscle, increase your force of contraction. If you contract harder, you're going to eject more blood. Okay. All right. Now, the one you probably will hear about right now is digoxin. Lots of side effects with digoxin, but it's a great drug to be used in this in this principle, in that it helps with contraction. It basically allows more calcium to be available for contraction. So it is used. They're moving away from it, but it is still used. And this is kind of how it works, right? So if you block, it's like a second order. If you block this pump here, you're going to end up with more calcium, intracellular calcium. If you have more intracellular calcium, you can contract harder. So that's all about inotropy, contractility. There's also negative inotropes. Again, remember I told y'all about these calcium channel blockers. If you block calcium, you block, she's knocked out, sorry. If you block the calcium there, there's not, it's the opposite of digoxin, right? If you have less calcium, it's not gonna contract as hard. And then beta blockers, right? You're familiar with propranolol. Those are just help to block that beta-1 effect, so it'll decrease your heart rate. All right, and this is a great little picture, kind of putting the three of them together. So preload and contractility are going to work together, right? You want a nice preload, not too much.
Sorry. Uh-oh. Hold on. Can you hear me, Kishore? It keeps disconnecting. Okay, we're good. All right, so remember they work together. So you want a nice stable preload. Now, why can't you say, is it there? Okay. Why can't you say, well, why don't we just have a ton of preload, right? Remember, that has to do with Starling's law. There is a point at which the preload gets too much and you can get diastolic heart failure or filling heart failure. So remember, you want to stay in that narrow range. And I'm just introducing y'all to this, but in term 4, y'all really get into it a lot. But so you want to keep that preload at a safe range to where it's not too much. You don't want to hyperextend it. So remember, preload, the filling, and your ability to contract are going to work together, and that force is going to be counteracted by your afterload or the pressure you have to push against. Okay, more on that. It's just important that you have a good understanding of this going forward. Now, I said we would break these down, these pressure volume loops a little better. So let's look at this. Let's say we increase preload, right? So preload's the same thing as end diastolic volume, the volume right before contraction, which will increase your stroke volume. So look what we did here. We increased our preload. We increased the blood in the heart, right? So we changed our end diastolic volume. So opposed to having from this here to here being our volume, we're going from this to here. So there's more volume there, okay? So with more volume there, you're gonna be able to contract harder. Again, there is a limit at which the heart can expand, but all we're saying here is by increasing preload, increasing our end diastolic volume, we're gonna be able to pump more blood, okay? More blood in the heart. Now, what if we increase contractility? We're not changing our end diastolic volume. Okay, your preload's the same. You're at a certain point for preload, but you're going to contract the heart harder. So once you contract, this is your end systolic volume, the volume that's left over after you contract. So if you contract harder, you're going to have less volume, right? So you went from this point, you contracted harder, now you're down to this point. So there's less volume in the heart, okay? Now, again, I said afterload, if you have an increased afterload or pressure you have to push against, obviously your stroke volume is going to go down because you're pressing up against a more narrow straw, right? So you're not going to be able to put more blood through that narrowing or that pressure. So your stroke's volume is going to go down. So basically, instead of going this normal curve where you're in systolic or after you eject blood would be here, since you have to press against more pressure, you'd have increase in systolic volume or increased volume after you finish contraction, right? So this is that pressure difference. You weren't able to contract as hard. I'm sorry, you weren't able to eject as hard because of that increased pressure you're pushing against. So there's some leftover blood in the heart or more leftover blood. So you kind of just have to sit with these and kind of talk yourself through them. But again, you can appreciate the giveaway here is that look how much pressure there is, right? Pressure means increased afterload. So the pressure is supposed to be here, it went all the way up to here. That's your increased afterload. All right, y'all could read through these. The only one you really need to focus on is this idea of physiological splitting. Basically just means when you take a deep breath in, you get a negative pressure gradient and more blood is going into the lungs, or actually, I'm sorry, more blood is returning to the heart. You're causing a vacuum into the heart as you pull everything in. So it just means that the pulmonic valve is going to close a little bit later than the aortic valve. That's all you really need to know about it. This is a normal process that you could see in patients. All right, now we talked about this. Remember, any flow against an open valve is forward flow, is going to be a stenosis. Any flow against a closed valve is going to be a backflow, and that's going to be a regurgitation. So first, you have to figure out what location they're talking about, which valve, and then you have to say, is it during systole or is it during diastole? Because you can determine what goes with what. So we talked about this too. Systolic murmurs, aortic stenosis. Why? Because during ejection, the aortic valve should be open. So if you hear a murmur, that means that valve that's supposed to be open is narrow, it's stenotic. During ejection, mitral valve is supposed to be closed. So if you hear a murmur at the mitral region or the apex, it's a regurgitation. The valve is incompetent. Diastolic murmurs during filling, aortic is supposed to be closed. So you get aortic regurgitation. And the mitral valve is supposed to be open. So during filling, if you hear a murmur there, it's a stenotic valve. We also have these PDAs, which we talked about in VSDs. Remember, VSDs, you'll hear holosystolic through the time frame of systole. And then PDAs are machine-like murmurs that go through systole and diastole. All right, so if we look at aortic stenosis, remember I said this tends to happen in older patients. It's age-related calcification. You're getting this increased pressure, right? Increased afterload, increased pressure at which you have to press against. Look at this crescendo, decrescendo murmur, right? These are all classic for aortic or aortic stenosis. So this is what you're going to see, this increased pressure. I like what first aid has to say about it. It kind of puts these two graphs next to each other so you can see this increased pressure here, crescendo, decrescendo between S1 and S2 during the ejection phase, during the systole. So all these words are interchangeable. I think the best way to do it is get with a group of people, get with yourself in front of a mirror. I don't know, just talk through it with someone. If it must be yourself, then so be it, as long as it's not me. Okay, so here we go. Increased pressure, aortic stenosis. You're pressing up against a stenotic valve, okay? It's not gonna change your your end-diastolic volume, but it will change your end-systolic volume, okay? Because that pressure, you're pushing up against the pressure, so you can't get proper ejection. Some's left over. You're having to press up against a narrow straw, okay? So decreased stroke volume because you're pressing up against a higher pressure, increased end-systolic volume, increased blood that's left over in the heart. This is how we calculate it. This is a very important equation. Your stroke volume has to be your end diastolic volume, your end filling volume, minus your end ejection volume. So how do we know we have a decreased stroke volume? It's supposed to be, this black one is what, 175 minus 100. So, so it's about 175. So it's about to be, well, we go down to 100, right? So it's about 75 milliliters that we're losing here. But look, if you have aortic stenosis and increased pressure, look how much less, right? You go from this amount of volume. So let me just, maybe it's easier if I annotate it. Right, so your normal pressure should be whatever this is, say 175 minus 100, right? So your end diastolic volume 175 minus 100, right? So your stroke volume should have been about 75 milliliters. But after this aortic stenosis, since you're having to press up against a more narrow valve, this will probably be what, 125? So you went, now you're 175. It doesn't change your end diastolic volume, but it does change this, minus 125, right? So because of that aortic stenosis, look at your ejection fraction. It decreased by 1/3, okay? So that's a problem. All right, so mitral regurgitation, if we look at this, this is a holosystolic murmur. It's not crescendo decrescendo, but it's holosystolic all the way through. So this is our mitral regurgitation. Let's look at what first aid has to say about it. Look, it doesn't crescendo or decrescendo. It's holosystolic. Okay, and you can see here, because we have regurgitation, some of the blood is going to go back into the heart, back into the atrium. So because of that, our end diastolic volume is going to go up, okay? And also your end systolic volume is going to go down. And I'll show you this on here. So, so what's happening? We're regurgitating blood back into the atrium. So if we're in our left ventricle, right? Some blood's going this way properly, but some blood's going back into our left atrium. Now, the blood that's going back into the left atrium has to be added to all the blood that's coming in. This is not an efficient process. This is why our end diastolic volume goes up, because not only is the proper blood coming in from the lungs to the left atrium, but you have to add all the blood that's going back, right? This is not good. You want your heart to go one direction. This is very inefficient. You're shunting it back into the left atrium. So all this extra blood has to be added. This is why, This is why our end diastolic volume went up. Now, why is our end systolic volume lower? because this is the amount of blood right here that we're regurgitating back into the left atrium, okay? So this is our proper graph that we're supposed to be working with. Look at all this. Now you might say, well, look, you're getting rid of more volume. And on the surface, it seems good, but that's not what we're going backwards, right? Even though we're getting rid of a lot of extra volume, we're regurgitating it back. So it's not getting to where we want it to go, okay? So that's how that works. When do we have this? During systole, right? Mitral valve supposed to be closed, all right? And again, it does seem like your stroke volume goes up and you're like, oh, well, that's great. You're getting more blood to the body. Not exactly, right? Since your stroke volume is going up and it's going back to the body, I'm sorry, it's going back into the left atrium, that's the problem, okay? So decrease in systolic volume, much increase in diastolic volume, but it's a not efficient process. All right, quickly we'll go through this. Aortic regurgitation, again, this is during diastole, right? During diastole, the aortic valve is supposed to be closed. So you could see that graph here. You could see it's during filling, so it's a diastolic murmur here, classically rheumatic fever. So you get an increase in diastolic volume. Why is that? Because the blood is regurgitating from the aorta back into the left ventricle. So again, this is an inefficient process. So the left ventricle has extra blood there. The difference between this and mitral regurgitation is mitral regurgitation kind of comes out here, whereas you could see here, you don't get that. So just in case they put it on the test, there is that little difference there, but I'll show y'all in a second when I have a picture of them all together. All right, so you're gonna get an increase in diastolic volume, increase in systolic volume, and increased stroke volume, but remember, this is an inefficient process because it's regurgitating back. Okay, mitral stenosis, again, diastolic murmur. We're looking at it here, it's during filling. The mitral valve is stenotic. So this is our graph here. This is when we talk about this opening snap. So when the mitral valve is supposed to open, it's stenotic or calcified or hardened, and it kind of opens and then it finally snaps open. So if they ever talk about an opening snap, they're talking about mitral stenosis. Let's look at our graph. So if we work through this, if the valve is stenotic, you're trying to get blood into the left ventricle, you get less blood in there. Why do you get less blood? Because it's going through, you only have so much time to get blood from the left atrium to the left ventricle, right? So this valve is stenotic. So since it's stenotic, you're going to have a decrease in diastolic volume. It went down, okay? So you kind of, again, you just really need to sit with these and work them out, but these things are going to be on your exam and you can calculate it here if you need to. But again, not a lot of blood getting to that left ventricle because the mitral valve is so narrow. Lots of stars on this slide, some buzzwords here. When in doubt, if you don't get it, just memorize this if you have to, but take the extra time to try to understand it because it'll stay with you long term. Now, I put it all together. This is everything from first aid. The one thing I wanted to point out, look at the regurgitations. If you are trying to differentiate, mitral regurg is going to have a lower in systolic volume. Aortic regurg kind of stays higher. So that's basically the only difference you're going to see there. But you can appreciate the aortic stenosis with the pressure, mitral stenosis with the decrease in diastolic volume. So look at that. You'll be good to go. VSDs, we talked about that. Holosystolic between S1 and S2. PDAs is our machine-like murmur through systole and diastole. All right, quickly we'll go through some imaging just so you can orient yourself. Remember, you're looking at the patient. This is the left side, this is the right side. Heart should go here. This is the apex, right? You would expect it mid-clavicular. You can see that aortic knob here, right? You would expect the superior vena cava, right atrium over here. Now, if we look at it here, remember we said right ventricle in the front, left atrium in the back, esophagus right here, kind of closed off. The descending aorta is going to be down here. Okay, so you need to orient yourself to this. You can see this aortic, the aorta here And then the carotid's coming up, brachiocephalic artery, brachiocephalic trunk, the superior vena cava coming in, right atrium, apex of the heart over here, interventricular septum. So right heart, left heart. You can see some of the branch points of the to the lung. So they obviously put some dye in here, but you can see the bones are lit up. So this is a CT scan. It looks like a modified CT scan. It's pretty cool. All right, it's 25, the pulmonary trunk. Yeah, it's coming off. So this is the arch of the aorta, and the pulmonary trunk dives off to the back. Yeah. And then you can see here we can see a picture of our trachea. You would expect it to be black because it's air-filled. Again, this is a CT scan, so air will be black. You could see this arch of the aorta, so it's coming up, and you just caught it right where it's peaking up and coming down. You can see these pulmonary arteries here, thoracic or descending aorta. So you get used to these. The more you look at them, the better you get. Here's our liver. Here's our big old spleen, the kidneys, the bladder. There you go, the psoas muscles, pelvis, your acetabulums. All right. Any questions? We'll take another 5-minute break. We're going to finish off with the Guyton cross plots and the EKGs. It's a little complicated, but it's not too much more. So we'll take a 5-minute break.
Imaging is tested. They won't ask you first order questions though. So just be aware of that. They prefer to ask you in association with something. A great example that Brady gave was like the coarctation of the aorta. That is a great one. They can just basically show you a rib notching and then ask you, based off of this, there's a weak distal lower limb pulse. And then they'll give you a couple of hints in the stem, and then they can, definitely give you a slew of options as to what the likely diagnosis can be. Oh, to get Brady's kind of recordings and Brady and Lindsey's recordings, they are posted on the Scrubs DES page as well as Dogmom DES, kind of the group description. And if you guys find that, then you guys can just click on it, bookmark it, because they are unlisted. Clinical correlations to imaging, absolutely. That tends to be their preferred way to ask questions on imaging. It's not going to be a first order thing. They're not going to ask you like identify the psoas muscles. It's just very second order, at least second or third order with these questions for imaging.
So yeah, so after this, y'all are going to move into some of the hematology, some of the blood components of stuff. So after EKGs, you really move away from the heart and start talking about heme, but we'll plan to have another review for y'all next weekend before your exam. Y'all's exam is the 7th, which is the day I fly out. That Wednesday, but the weekend prior, so I think it's next weekend, we'll do one more review for y'all and make sure y'all have all the hematology stuff down, blood clotting, the coagulation cascade, which is a pain, but we'll go through that for you guys too. If you want to get a head start on it, the review from last time is posted, so y'all can always look at that. And the slides. The link to the slides is always in the YouTube description. All right, so let's finish this off. So cardiac output, right? So this is again what I was talking about in the beginning when we talk about the left heart, the strong aspect of this side, right? Because it has to have increased muscle to pump systemic blood through the body. And then the right heart is more of a delicate side, right? It has to be delicate in that it pumps blood to the lungs. They have that aspect of it dissipating, and it dissipates the pressure while compensating for the same amount of volume, right? So when we talk about the left heart, we're primarily going to be talking about cardiac output. How much output can you get to the body for systemic circulation? When we talk about the right heart, we're talking about venous return. Venous return meaning how much blood can you get back to the heart so that you could eventually get it to the left side to pump. So remember, they're like a couple, they work together. Left heart will pump, right heart will fill up, right? Yay. Some equations, y'all need to know these. We'll get into some of these when we do the hematology stuff. This is a really important one, but y'all haven't touched on it yet. So we'll wait on that. But definitely make sure you know these mean arterial pressure. There's some quick ways of doing it, stuff like that. All right, so we're going to break this into two sections to do the Guyton cross plots. Left heart is cardiac output, right heart is venous return. So the point of the Guyton cross plots is if there's a problem on the left side, the right side can compensate and vice versa. So let's talk about factors that can affect your venous return, can affect the right heart, can affect the amount of blood going back to the heart, okay? That's our venous return. Let's say you have increased blood volume. If you have increased blood volume, there will be more blood going back to the heart. Yes? Okay. Now, venomotor tone. Remember I talked about those pooling systems in the venous system. If you have, if you want to get more blood to the heart, you decrease the size of the pools. By decreasing the size of the pools, more blood can get to the heart. So venoconstriction by definition is decreasing the size of the pools or decreasing your compliance. Compliance is another word for how much you can hold, right? How compliant are you? So if you decrease the size of these pools, you're going to increase the venous return to the heart. Increase sympathetic tone, always sympathetics is going to squeeze down, venoconstrict, decrease your compliance, increase venous return, right? Increase, it will eventually increase your end diastolic volume or your end filling volume. More blood, more you can put, more preload, right? Okay. Now, arteriolar tone is a little tricky because it affects both cardiac output and venous return. But just know that if you have on the left side, the arteries are constricted or you're increasing your afterload basically, then not as much blood is going to get to the right heart. Not as much blood is going to get to those pools. So you're going to have decreased venous return with that, okay? And I'm pointing these out just so you can see how the questions are set up. So just bear with me here. Now, the vascular function curve is going to correlate to our venous return. So this is our first line we're looking at. This is going to correlate to the right heart. Our baseline at equilibrium, you want your right atrial pressure at +2. If it deviates, that means we're dealing with some sort of compensatory mechanism or some compensation. But if everything is standard, you would expect your right atrial pressure to be 2. So this correlates to our venous return to the heart. Now, let's take the parameters we looked at. If we increase the blood volume, then we would change this curve and there'll be increased venous return to the heart, right? We went from here to here. If we decrease our blood volume or have hypovolemia, right, we're down here, okay? So decreased blood volume will be decreased venous return to the heart, okay? Now, same thing with constriction. Let's say we constrict these pools, right? We make these pools smaller. That means the only way for the blood to go is to the heart, right? Decrease pools. So we're gonna increase venous return. Let's say we make these pooling systems larger or we have increased compliance, more held in the venous system, venodilation, then, right, so less venous return to the heart, okay? Because you're gonna be pooling it in the venous system. And like I said, the arterial vasodilation, it's a little more complicated, but basically, so let's say you vasodilate, right? You dilate your vessels. That means more blood can get from the left side all the way to the right side because the vessels are larger. So if that's the case, a decreased total peripheral resistance basically correlates to your blood pressure. So if you decrease the resistance, you're vasodilating. So more blood is able to get around. So eventually you're going to get an increased venous return. If you vasoconstrict or you increase the resistance on the left side, the arterial side, or the arterial side, then not as much blood can get to the other side, right? Because you have smaller vessels. So we get increased. You get decreased venous return. All right, so yeah, so that's what we talked about. So when we talk about this vascular function curve, or this right heart curve, or this venous return, these are the things that are going to matter. Now, easily enough, when we talk about the left heart, or our cardiac output, this cardiac performance curve is what we're going to look at. The main factor here is going to be how much we can contract the heart. Now, like I said earlier, the arteriolar tone comes into play, but basically we worried about contraction, right? The more we contract, the more blood flow. So let's look at it here. This is our other curve. So if we contract harder, this should look familiar with the sympathetics, right? The norepinephrine. If we contract harder, more blood is going to leave. So we have an increased cardiac output. Contract less, decreased cardiac output. All right, so afterload works in the opposite fashion. If we have increased pressure to push against, we're going to have a decreased cardiac output because you're pushing up against the higher pressure. If we vasodilate or decrease the afterload, it will be easier to pump blood. Therefore, we'll get an increased cardiac output. Okay, you can see that here. Increased preload, increased stroke volume, right? Because we have more blood there. Increased afterload, decreased stroke volume, because we're pressing up against more pressure. Increased contraction means by definition, you're going to have an increased stroke volume. You're pushing out more blood. Okay, why in the world does all this matter? Well, because one side, if there's a failure on one side, failure of one partner, the other partner has to compensate, right? So we're going to overlay these guide and cross plots. Now it works out nicely, at least for me, because remember cardiac output is red. We're going to use the red line because it's oxygenated. This is the left heart. Blue line is venous return. So that's going to be our right heart. Okay. So we're going to overlay these. Now, if the cardiac output right here correlates to the venous return, then our pressure is stable at +2. Our right atrial pressure is stable. And that's what we want. We want a decent cardiac output and we want a decent venous return. Everybody's working together and we keep our pressure stable. Keep in mind that steady state is always going to be at +2. Now, this is where the problems come in. Let's say we have to increase contractility, right? Here we go. So if we increase contractility, we're changing the parameters of the curve. If we increase contractility, you could see if we overlay it on the vascular function curve, the venous return will change, okay? And that's what we're looking at here. So if you increase contractility, it's going to change the parameters of the curve. Same thing if you decrease it. Now, right here, so you can see that if you decrease contractility, you're changing the parameters, right? Where does it overlay? Now, what happens when you change the parameters? Well, we're off of equilibrium now. We used to be at +2, now we're over here. So that's not good. You want to stay here. Now, the other side, the right side can compensate for this decreased contractility by getting more blood. So decreased contractility basically means left heart failure, right? Because you have a decreased cardiac output. So if that's the case, if you have decreased blood going out to circulation, the only way to compensate for it is to get increased blood back to the heart from the right side. So if you have decreased ability to contract, you need to increase your venous return, right? Which will increase your preload. So even though the heart can't pump as hard, at least you have more volume there to be able to pump, okay? So that's where they compensate, and we'll take a look at that in a second. All right, so now let's say we change the blood volume. Remember, what is blood volume a component of? The vascular function curve, or the venous return curve. So let's say we have some sort of injury, patient loses a lot of blood. If we lose a lot of blood, what do we have to do? Well, since we're not getting as much venous return to the heart, how do you keep blood flow going? Well, the left heart has to compensate by contracting more. So if you have a decreased venous return, how do we keep a stable cardiac output? You have to increase contractility, right? So right heart's going down, left heart has to compensate. If you contract harder, you're pumping more blood, you can keep the cardiac output stable, okay? So the point of it, and the point of me telling you in the beginning of separating the left heart and the right heart, is for this purpose. They can work separately, but they can compensate for each other. Now, again, when we do this, we are off equilibrium. It's not a perfect situation. So for a while, that's okay. You can compensate, but eventually you go into decompensated heart failure, right? And the other side can't exactly compensate. All right, so blood volume's a component of the vascular function curve, the venous side. And I told you arteriolar constriction is kind of complicated. It's a component of both. So it's able to kind of titrate or stabilize your blood pressure on both sides just by vasodilating and constriction. So just keep that in mind. And same thing if you vasodilate here. So the first one was vasoconstriction, increasing resistance. You stay stable, but you're decreasing the amount of blood. And if you decrease resistance, you're vasodilating, so you're increasing the amount of blood, but you're still stable, okay? That's a little more complicated, but just keep the separate parameters together. So the first thing you need to ask is, what parameter are we affecting? Are we affecting the amount of volume, right, for the vascular function curve that can get back to the heart? Or are we talking about how well the left heart can pump, cardiac output? Okay, the other must compensate. So let's take this. Patient in heart failure. So the cardiac output drops. Okay, so the only option here is to get more blood back to the heart. The heart's not going to pump as well, so you have to put more blood in there to keep the ejection fraction stable, or to keep the heart pumping adequate amounts of blood. So right here, when we replot it on the normal vascular function curve, you could see that this is decompensated. We didn't change the vascular function curve yet, okay? So this is just a patient in heart failure. So now what happens if we compensate for it? So these black lines, you can see, you know that that's our equilibrium or our normal pressure because we're stable at +2. So this is where we started. Now the patient goes into heart failure. So we see a decreased cardiac output, all right? So this is the point where it's decompensated. This is the point where they're in heart failure, but there's no compensation by the right heart. But look what the right heart is able to do. The right heart is able to increase the blood that's going back to the right heart, and it's able to compensate for the cardiac failure. So even though your heart is not pumping as hard, this is telling you that there's more blood getting back to the heart. So the right heart kind of saves the day. Now, there is a price to doing that. And look, we're off of our equilibrium. So this is cool for a little while, but eventually, you know, over time, this will become a problem. No, heart rate, we'll get into that when we look at EKGs. You really don't need to worry about that. This is just kind of worried about volume here. Okay, so point is, this is our equilibrium, +2. Patient goes into heart failure, they're down here, right heart has to compensate, all right? So at this point, even though you're not pumping as hard, at least you have more volume, all right? At least you have higher venous return, so you can keep an adequate cardiac output. All right, but you could see the compensation it has to make. All right, so let's take hemorrhage for an example. So paint this picture for yourself, all right? This is normal. So this would be at +2. What happened? Okay, looks like the patient lost blood, okay, right here. Now, by the patient losing blood, yeah, so, oh, sorry, did they change the color? They did change the colors around, sorry. So it looks like the patient lost blood here, right? This is our vascular function curve. So at this point, see, because when we look at it as decompensated, we look at the changed curve with the normal curve, right? So let me annotate this to make it easier. I don't like that they changed the colors. Okay, so this is our normal cardiac output curve, or cardiac performance curve. Okay, this one right here. So when this patient lost blood here, at this point, we trace it over the normal cardiac performance curve, which is this black one. So basically what this is saying is that the heart's pumping, but the patient lost a lot of blood, so not as much blood's getting back to the heart. So decreased venous return, right, because of the hemorrhage. So how do we maintain cardiac output? Well, now the left heart comes to save the day, right? And that's this point here. You could see the curve comes in, so we have our vascular function curve, and we increased our contractility here. See, look at the change in contractility. This was our original, and this is our new. So even though we had decreased blood volume, we increased contraction of the heart, and now we're able to stabilize. So if you have decreased venous return, you increase contraction of the left heart, or contraction. And this allows us to keep a stable cardiac output, keep a stable blood flow. So I know this is complicated. You kind of just have to sit with it, but I want you to try to be able to put these pictures into words, right? Go through the process. Normal, then we go to decompensated, right? Because of this hemorrhage. And then we say, look at this increased contractility. So the left heart's able to compensate for the right heart problem, okay? And again, that comes at a cost, because if this was our +2 equilibrium, we had to move that lower, okay? So that cost does come into play over time. Now, it's interesting about exercises, both the cardiac output increases and the venous return increases. So during exercise, you're able to stay basically at equilibrium, okay? All the while getting more, increasing your cardiac output, right? Because you need it, because you're working out. All right, so that stays normal. This is from first aid, so you kind of see the differences here. Again, you just kind of have to sit with it and work it out on your own. All right, so let's look at the action potential quickly. I think Dr. Toledo taught y'all this, so he's a good dude. He's a really good teacher. So we're looking at the different flows here. So this is the classic myoepithelial cell, or this myocyte, excuse me, yeah, myocyte cell. So this is our action potential. So classically, get increased sodium or sodium influx into the cell. Then you get a potassium, which will efflux out of the cell. So this is the point where the sodium channels close, potassium channels open. Now, very importantly and different from skeletal muscle is this plateau phase. Now, by having this plateau, basically, shit. Hold on.
Brady, I think your headphones will keep going in and out, because whenever your audio comes back, it changes the quality.
Oh,
so I think it's your headphones.
Yeah,
you're back.
It does that. Okay. Okay. So basically, we have sodium efflux, then sodium channels close, potassium channels open. Now, what's very important in the cardiac myocyte is this phase here, this plateau phase. This basically allows for filling of the heart. Now, if you think about skeletal muscle, you don't need this phase, all right? So you can get tonic contractions of skeletal muscle. This phase is very important, this calcium phase, because it allows time between contractions of the heart for the heart to fill. Okay, then after this plateau phase, you get further efflux of potassium, and then you get back to stable resting potential. Okay. And you could see here, this just correlates, a down slope correlates to efflux. So you would expect potassium to be above it as, this is influx, right? Sodium and calcium go in the cell, potassium goes out the cell. Okay, these delayed rectifier channels. So again, this refractory period is very important. Absolutely refractory means you absolutely cannot have a contraction of the heart during this phase. This makes sure that you have time to fill the heart, okay? Relative refractory period means technically you could have a contraction, but it usually doesn't happen, or it's not supposed to really until you get back to resting membrane potential. This is important. This could be tested. You kind of want to know the speed at which things change, right? So the speed at which the conduction goes. So yeah, you could just read these here. Electrical conducting system, the speed goes faster than the myocardium, and the nodes is the slowest. So just in case they ask that. All right, now the action potential curve is different. You have these funny sodium channels here, and then the zero phase is the calcium, right? So you get these calcium channels that open, and then after the action potential goes, then you have these potassium channels that come down, right? So potassium efflux from the cell. So I think putting these graphs on your exam is fair game. They could definitely do that. So you know those. You know the difference between what the graph on the myocyte looks like with that plateau phase versus the action potential. So this is this SA node just firing. Okay, so some more definitions. Chronotropy means heart rate, chrono meaning time. So the heart rate, chronotropy, anything that affects your heart rate is related to chronotropy. And we talked about inotropy, that has to do with how hard the heart contracts. All right, so we have different components. You know, sympathetics is gonna run away from a bear, you need to increase heart rate. Parasympathetics, you're digesting, stuff like that. All right, and then a little bit more lusotropy, relaxation. But again, when we talk about inotropy, remember the drug we talked about, the Digoxin, helps with that contraction, right? That increased calcium. Okay, quickly go through this. I think this was a DLA. So basically, all you really need to know is of the different regions, what is the primary method of oxygen delivery? So different areas go through different processes in maintaining the amount of oxygen. So they all go through this auto-regulation where you get blood flow. And then there's this functional sympatholysis, right? Where the sympathetics primarily control the amount of blood flow and the amount of oxygenation, but you can also have a change in the local metabolite. So under stressful situations, local changes or local factors can take over the sympathetic, such as hypoxia or something like that. And this is classic in skeletal heart brain. So if the brain is under sympathetic control, you're just vasoconstricting and dilating, and all of a sudden you get hypoxia, and the metabolites in the brain start going off, and you have different fluxes in potassium and sodium. Then the local control can take over. Okay, and there's some more definitions. This metabolic hyperemia, just the metabolic concentrations. But again, this is just if you have an understanding, like this slide's really important. It kind of just tells you what is the primary control, okay? Which one uses which one's used in different situations. Okay, last topic, EKGs. Now, I know this is difficult. I know everybody's tired, I am too. But we'll try to knock this out. So EKGs is basically just the electrical potential that goes through the heart, right? It starts at the SA node, it goes to the AV node, it goes to the bundle of His, and then to the Purkinje fibers, okay? So when we look at this classically, there's a P wave that correlates to the atria contracting. Then you have a QRS wave that correlates to the ventricle contracting. And then the T wave is ventricular repolarization. Now, if you're wondering where atrial repolarization is, why do you see it for the ventricle and not the atria? It's hidden. The atrial repolarization is hidden in here. So classically, this regular rhythm, right? You would expect the P, QRS, T, and then a little U wave, which is not too important. But there are different arrhythmias and problems that y'all will get into later that correlate to differences in this classic wave. So you would consider this a regular rhythm, okay? Now you worry about rate and rhythm. They're two different characteristics. Rate is gonna be your heart rate, right? You don't want tachycardia, bradycardia. You want a stable heart rate between 60 and 100. Rhythm is gonna be this. This is our rhythm. This is our dance moves. P, Q, R, S, T, right? This is what you wanna see. If it gets funky, then it's a bad rhythm and you need to do something about it. Okay, so this gets complicated too. There's some tricks to doing these. So lead 2 is what's going to be most important. Okay, why is that? Because we see our classic rhythm here. So if they give you a strip like this or the complete leads, you want to look at the rhythm set or you want to look at the rhythm of lead 2 because that's your classic. So you can see here this P, QRS, T, P, QRS, T, P, QRS, T. You always want to have a P before the QRS, T, right? The atria should contract before the ventricle. So when you're looking for normalcy, use this. Now you also want to use, oh, we'll go through that in a second. So just some nomenclature, you got to get used to this. The segments are just timed out to see, I don't remember them putting questions about the time, but I think Kishore had mentioned that they did want y'all to know last term, yeah, the different time frames, like the different timing segments that are supposed to be. So make sure you know that. And then the intervals include the wave and the segment. So you just want to keep those in mind. So they could ask you any of these. So get used to using this nomenclature when you do it. And again, like I was saying, it's probably important to know these time frames as well. Now, this is where it gets complicated, but fortunately, it's not super highly tested. So I'll briefly explain to you how this is supposed to work. These leads are oriented in such a way that it gives you an additive vector, right? So if you have 2 leads, so each 2 leads correlates with a positive and negative pole. So you can calculate all the different leads. But if you're just looking at the transit from one lead to the other, let's say, you could say one lead goes this way, and then the other lead goes this way. And it's kind of straddling the heart, right? So the point is, if you take 2 leads like this, you can figure out the additive vector through the heart, right? Because some vectors are going to be stronger than other vectors. So if you have a strong vector and a short vector or a weak vector, the additive vector is going to be closer to the stronger vector. This is not terribly important. I'm just explaining how this kind of works for you guys. Okay, so the point of doing these leads like this is so you can figure out the different vectors. So you take 2 leads, you add those together, you find the vectors, and each of the different leads correlates. That's why when you look at these different leads, these are the differences, right? These additive vectors at different points, okay? And like Kishore was saying, people do fellowships in understanding electrocardiography. So like, this is very bare bones, trying to just introduce y'all to this for sure. Okay, so if you look at lead 1 and lead 2, right? Lead 1 gives you a positive vector, lead 2 gives you a positive vector. And if you look at lead 3, anytime the up component equals the down component, right? The positive equals the negative, right? They cancel out and that's equal. So you could see here, the upstroke and the downstroke is equal, right? But this, obviously, the upstrokes are higher, so you get a positive vector. Okay. Now, by calculating these vectors and knowing what a normal heart should do, you could say, okay, this heart it's conducting normally. But if you have some sort of previous MI, myocardial infarction, and you have dead tissue, it's going to change the electrical polarity of the heart. So it's going to change the way these vectors form. So you'll see when you get into y'all will briefly touch on some of the pathology, like a recent MI will really result in a STEMI, which is called ST segment elevation, right? So you'll end up getting problems with this electrical potential. Okay, that's as far as I want to go with that, because that's really not highly tested. They're not going to ask you about that. They're going to ask you to correlate some of the differences. Heart rate, this is the way I do it. There's a million ways to do it. I just remember these numbers. It's very easy for me to do it this way. So I remember every big box, you just calculate 300, 150, 175, 60, 50. I think it's a fast way of doing it. Whatever works for you, but this is the way I do it. So if you just count the big boxes, right? So from R peak to R peak, the QR, this is our QRS curve. This top peak is the R. So you calculate R to R. So big box, first big box, 300, 150, 100, 75 and 60, R's between 75 and 60. I don't know, say 70, 67, close enough. All right, that's how I do it. Okay, this is what I was saying. So if we have some sort of problem, it's like a myocardial infarction, it'll change the electrical polarity or the vector of that heart. So you can look at it, what you expect a normal heart to do, and you can check the differences. And by analyzing that, the machines do it now for you. I mean, it does get more complicated, and you could, people, cardiologists can read into it more than that, but you could literally read out on this thing. It's like person just had a heart attack. So yeah, and specific leads. But yeah, so this would relate to a STEMI, right? This ST segment change due to that dead tissue. All right, now, if you had subendocardial, like a mild myocardial infarction or MI, it would be subendocardial. And then you wouldn't get this ST segment elevation, but this is a full transmural infarct, right? So all the electricity that's supposed to go through is modified by this dead tissue. So that's why you get this ST segment elevation. Classic, patient comes in with this, chest pain, elephant on his chest, pain radiating to the left arm. You check this, he's got a STEMI. Send them to the cath lab. It's a problem. All right. Now you can overlay, this is an important slide to know, you can overlay the leads across the chest. So if you look at it, V1 starts on this side, then V2, V3, V4, V5, V6 kind of wraps around the heart. Now, if you know where you get the problem at, you can kind of isolate on the heart where everything is. So this anterior septal area is the V1, V2 lead. This is the bad one. This is this LAD. So this left anterior descending, the widowmaker in this area. And then as you transverse across the left side, you can correlate to these different leads. Now, this is what they probably test you on, this mean electrical axis. And sorry. So this is what we're gonna do. Get used to writing these out. Now, I want to preface with this. They do know you don't have scratch paper, right? So when we took this, when I took this, when Kishore took this, we didn't have scratch paper either. So they have made these easy. Ideally you can write these out and you could like make the graphs to make these work. But if you don't have scratch paper and you have to do it in your head, I'm gonna show y'all how to do that. Now, the way I do this takes about 1% more effort, but regardless of the leads that they give you, you can do it. So there are different methods like the thumb method and all this other stuff, but those methods rely on them giving you a certain set of leads. The way I do it, they can give you anything and you could figure it out. Okay, so I'm going to show y'all my way. If y'all like it, go for it. So first we're going to lay the the chest leads out. So one's going to point all the way to the right, and then you go 60 degrees to 2, 60 degrees to 3 from that point. So 120 degrees here. And then you could see where the arrows are pointing. Now, when you lay the limb leads out, you want to go straight down to the feet, and then left arm, because you're looking at the patient, and right arm. Okay, now this is kind of bigger. If you want to practice with these and draw them out, you could just print one of these out off Google and practice with it. So remember, the arrowhead is going to point to the positive direction. So the opposite side of it has to be the negative direction. Okay, so that's how you want to do that. And this correlates, right? So 0 is going to be lead 1, 60 degrees, lead 2, 120 degrees. Okay, now this is the way I do it. So they'll give you, you can have any lead that they give you, and you can calculate it. So you want to calculate the positive deflection minus the negative deflection. Okay, so if you get, you could see this correlates to 2 units up. So this would be a positive 2. You can see this negative deflection correlates to a negative 1. Okay, and that's how you're going to plot it on the graph. And here's another example. We see our positive, and they wrote it down here. This is a positive 8. You count the small boxes. Positive 8 deflection, and then a negative 4 deflection. Okay, so obviously we get a positive 4 of our amplitude. And then the negative deflection, we have positive 1 and negative 7, so it's a negative 6. So let's do this. Let's say they give you lead 1, and it correlates to a positive 6 and a negative 2. So when we add those together, we get a positive 4, right? Or subtract them, either way. You get a overall of a positive 4. And let's say they give you AVF, right? F for foot. And we get a positive 3 and a negative 1. All right, so plus 3, negative 1. So we end up with the plus 2. All right, so now we're going to plot this out. So I told you that the arrows, it's important to know which way the arrows are. So when if we're in the positive direction, we want to be able to plot this. So let's use the little ticks. Each little tick is 1. So 1, 2, 3, 4. All right, that's our 1. And then on AVF, we'll have to arbitrarily do it. They're not marked. So 1, 2. Now, the point of this for right now, because you don't have scratch paper, is to figure out what quadrant you're in. So then you could figure out, if you draw a straight line or a parallel line right there, the crossing point is where it ends up. So you know, if they give you this right here, that you are in this quadrant, this one right here of the 4 quadrants, which means that equals a normal axis. And I'll go through the axes in a second, okay? So this is a normal axis. Now, I would bet money that they would give you perpendicular axes, meaning they'll give you like 1 in AVF, or they'll give you AVF and negative 1, or any ones that are perpendicular, because in order to do complex ones, you really need, like this right here, you really need to be able to draw it out, okay? Because you need to see where these points intersect. So I really feel like they'll give you perpendicular axes, okay? So let's go through, okay, let's do a complex one just in case, so I can show you how this is done. Let's say you had paper. So let's say lead 2 is 4, okay? So lead 2, this is the positive direction. And we're gonna, so the red line is 4, 1, 2, 3, 4, okay? AVR is negative 2, right arm, so AVR, but we're on the negative side. So 1, 2. Now, remember, you make a parallel line and find where they cross. right? So when you're doing these freehand, there's some give and take, some human error there. But you could see that this falls into this quadrant, right? Where they cross right here falls into this quadrant. So this is the right axis deviation. And I'll show you all the differences there in a second. So my point being here is to properly do this, the teachers understand you really need scratch paper to do it. So I really do think they would make it easy on you and no. So let's, for example, say they give you a +1. Come on. +1, any positive in lead 1 and any negative in lead AVF. What quadrant do you fall in? +1 and negative AVF, so opposite the arrow sign. So you have to fall into this quadrant, right? That's as far as I think they'll make you go, just because you have to do it in your head. Okay, let's say, for example, they give you a positive AVF and a -1, negative in lead 1. What quadrant do you fall in? Positive AVF, and remember we go opposite the arrow, so -1. So now you're in this quadrant, okay? So I really think that's as far as they'll make you go without scratch paper. So you can map it out, you can do practice questions with it. But technically the way I do it, they could give you any leads and you'll be able to do this, okay? So you could practice with these. They could give you, say, AVR, like this, and correlate. I guess that doesn't work, no. So let's say they gave you, what's perpendicular? I guess AVL and oh yeah, okay, so like 2. Let's say they give you +2 in lead 2. And they gave you +3 in AVL. Now you should be able to figure this out in your head, like once you practice these. So +2, remember we're over here, positive AVL, we're over here. So regardless of the actual individual numbers they give you, no matter what, you're gonna fall in this quadrant, okay? But like I said, they'll probably really limit it for you guys just because like they did for us. It was straightforward for us. So I don't want y'all to stress too much about it. Now, what does it mean to fall into these different quadrants? Now, if you fall into this quadrant down here, you're in a normal axis. If you fall into this quadrant, and technically it's changed now, it's changed -30. It's not 0 to 90, it's -30 to 90 is considered normal. Okay, so that makes it a little tricky. But I have a better picture of it coming up. But anything from -30 to -90 is a left axis deviation. Makes it easy because if there's a left axis deviation, you have a left heart problem, like left ventricular hypertrophy, okay? If you have a right axis deviation from +90 to +180, it's usually a right heart problem. So say right ventricular hypertrophy, okay? So right and left go together. That's as far as I think they'll make you do, so don't make this more complicated than it needs to be. These correlate, so probably what you need to know on the exam. They'll give you a lead, or they could give you, they could give you an EKG and give you a +4, sorry, let me get that better. Give you a +4 - 2, right? In lead 1, and you need to be able to correlate that this equals a positive deflection, right? Because 4 - 2 is 2. So that would be a positive deflection in lead 1. So you'd be over here in this region, okay? Anything, right, but like I said, anything you'd have to be able to do in your head. So it should be straightforward. This kind of gets into what the right axis deviation, again, it's usually right ventricular hypertrophy. a lot of times, yeah, that ends up being secondary to pulmonary hypertension, but I'll get into that later. And then left ventricular hypertrophy tends to be due to increased afterload, right? Because you're pressing on too much pressure, so the left heart has to work harder. This is the thumb method. If you want to use that, I don't know, go for it. I just like the way I do it because it's a fail safe. And lastly, this is the proper way to do it. So anything that falls from -30 to +90 is considered normal. +90 to +180, it's right axis. So just make sure you know these. And yes, very good point. If you get an equal, say +2 and -2, that's equilateral, right? So it's actually a perpendicular line from the axis, right? So you get you're basically at 0. I doubt they'll give you that. They'll give you some sort of deflection, so you won't have to worry about that. But for anything that's equal distribution like that, you just make a perpendicular line from it, and that's how it works. That is all I have. I know that was a lot for you guys. Work with a question. Yeah, if y'all have a question, I mean, like that's just basically how they would do it, right? They would give you something like this. Would be a good question. You had a patient come in and you did EKG and they had a deflection of +4, or they would give you like a +4 minus, or sorry, +6 minus 2. So that would give you lead 2 to be +4, and they would give you a -2. So say, whoops. So say +1 minus 3. So in AVR, you get a total deflection of -2, right? So that's what they would give you in the stem of the question. No, it won't always be lead 2, but I do think for the test, they'll give you perpendicular lead so that you could think of your head, if this perpendicular lead is positive and this one's negative, it'll be very easily distributed into a certain quadrant. They won't make you overlap stuff because you really do need a calculator to do that. So yeah, but yeah, so just remember, you'll be able to do these in your head. So the whole point is not to get an exact distribution of where it is, like a +60 deflection. You really just need to know it's in what quadrant it lands in. Okay. And yeah, no worries. I'll post this a little later. We have another review. We're doing a term 3 intro thing for these guys in a little bit. So I'll get this up later tonight. And as always, y'all could message us if y'all have any questions.